Assalamu alaikum, everybody, to all the participants who have joined. My name is Dr. Athar Saeed. I am a graduate from the King Edward Medical College, 1986. Lots of my friends are here. I'm a clinical gastroenterologist and I work in the northeast of England near Newcastle. It's a lovely, beautiful, sunny morning in Durham, where I live. It's a lovely university town. This is our third symposium regarding universal healthcare access. And it has gone from strength to strength from the time when we started 2 years ago with the help of Aasim, who is here, and Khalid Gondal, who is also here, and Mohammed Tufail, who always supported and bought into it, who is the uh, current chair of the alumni in the UK. So our ethos is threefold as far as I am concerned. One is to build a knowledge base so that all of us work on the basis of uh, analysis of data that we acquire and build upon so that we can inform our decisions regarding providing access to healthcare to all of the Pakistani citizens. The second aspect of this program is to raise awareness among common people, doctors, healthcare workers, but also Pakistan, common citizens of Pakistan who should be aware of their rights and they should demand uh, the facilities that they need and are available in many countries to many nations in their neighborhood. And the third aspect is to actually support people who make policy, such as politicians, civil servants, and but also to hold them to account, to ask them about their plans, their policies, and their performance. So, to summarize this, I would say that the ethos is informed activism for healthcare. So we will start in a few minutes after comments by Mohammed Tufail and Khalid Masood Gondal. We have divided today's symposium into four sections to start with, four parallel sessions. This is exactly a replica of the physical actual symposium that we held last year. This year, for obvious reasons, we're doing it all on a virtual platform. So the sections are health service. I know that there is a lot of development in reforming the health service in Pakistan, starting with the present government in the KP province, but also coming on to the Punjab province. I know that some of us have been involved in the concept, visualization, and implementation of these reforms. So the highlights of this section will be a talk by Aasim, followed by Dr. Yasmin Rashid, and also a live debate between Faisal Sultan and Professor Ashraf Nizami. The second section is regarding health financing. We have two presentations from the UK, from Mahmood Adil, um, who heads one of the data analysis sections in the Scottish NHS, and also Shafiq Gill. We also have a world-renowned authority on financing of health services through insurance, Jishnu Das, who will be joining us from Washington. Um, the third section is regarding infections and vaccinations. And Hafeez will talk about Pakistan's preparedness for COVID vaccination. And also we have a presentation about COVID modeling by Zafar Yassin, and followed by three talks on hepatitis C. As you may know, there is a worldwide target by WHO to try and eradicate hepatitis C by year 2030. And many nations are on the way to achieving that. We have actually included a section on education this afternoon in Pakistan, this morning in the UK. We believe that universal healthcare cannot be fully achieved without universal access to education, and both are mutually complementary. We also think that education and health are fundamental human rights and can only be achieved through state action and society support, and not merely through philanthropy and charity, although those are also very important aspects. So our final section um, will consist of talks by a famous health economist, Syed Maroof, who will talk about data analysis and the empirical basis on on which we should make our policies. And this will be followed by Amjad Chima regarding training of doctors, and Yasmin Rashid about the achievements and plans of her government. And Faisal in the end will talk about the role of the Federation after devolution. So there is another section in the middle regarding poster competition. We had a very good response to our invitation to poster competition, which are actually devoted to various aspects of developing innovations and also developing health service in Pakistan. So there will be short oral presentations, and in the end, we will decide who are the 3 winners, and they will be given cash prizes in the end. Right at the end of the whole program today, which will be around 8 o'clock, starting about 7:45, there will be a surprise event, which is known only to me and Khalid Masood Gondal, and not even to my team. So don't go away and wait for that. So I'll now hand over to Mohammed Tufail, who is the president of KEMCA UK, to say a few words. And following that, Dr. Khalid Masood Gondal. So Mohammed Tufail now.
Assalamu alaikum, and thank you, Dr. Athar Saeed. So I'm a consultant pulmonologist at University Hospitals of Leicester, and I'm the current chair of KEMCA UK. So on behalf of our executive committee and trustees, I welcome you all on this symposium. So King Edward Medical College Alumni Association of UK is an alumni association of nearly 500 Kemcolians who are serving in the NHS system in the UK. We have got our constitution, and our main aims are to help our Pakistani people and faculty at KEMU to promote healthcare and education. So this Universal Healthcare Symposium is one of the key elements of our ethos and program, as mentioned by Dr. Athar Saeed. We work on the principle of فَمَنْ يَعْمَلْ مِثْقَالَ ذَرَّةٍ خَيْرًا يَرَهُ. So any little effort of khair, of welfare for our own people in Pakistan, that is where we are, that is where our role is. We from KEMCA UK platform take pride in declaring ourselves the true servants of our patients and our also fellow Pakistani citizens. We are very happy to extend our help wherever it is needed. We are always delighted to collaborate with our own alma mater. And for any healthcare and education related project in Pakistan, we have no political affiliation. Our main aim is only and only improvement in patient healthcare through our universal healthcare program. So it will be unfair if I don't mention a few names here who have worked very hard over the last 6 months or so to bring whole of this program together. So I'm very grateful to Dr. Athar Saeed, who is the program director for this Universal Healthcare Symposium. He has worked day and night and burnt midnight oil to bring this program together. And then my sister, Dr. Tabinda Dougal, who is the secretary of KEMCA UK, and she is always there for her advice and experience. Dr. Rana Hafeez is chair of our charitable projects, and he is the most generous of all. And we are very lucky to have Dr. Adeem Mutla Raja and Dr. Shafiq Gill on board, and we always benefit from their wisdom and experience as well. Dr. Asif Khan and Dr. Abdullah have been very pivotal in bringing all this program together and setting up the IT system by the Kemcolians themselves. And last but not the least, any project in Pakistan is not possible without help of the faculty and leadership there. And we, from our bottom of our heart, are very, very grateful to Vice Chancellor Professor Khalid Masood Gondal Sahab, who has always been very receptive for all the collaboration whatsoever we have suggested to him. And I will not be wrong to say that in our 24 years history of KEMCA UK existence, he is the best VC who has always helped us in coming there. He always welcomed us there. He always took our ideas on board and collaborated with us. Let it be the MDTs and grand rounds which we do on Saturday mornings to improve the education of our pulmonary and critical care teams there and nursing staff, or let it be provision of PPE or provision of education. And again, the main aim is the improvement in the healthcare of our common people. So I will invite my own teacher and great educationalist, Professor Khalid Masood Gondal Sahib, to say a few words.
Bismillahirrahmanirrahim. President KEMCA UK, Dr. Tufail, Dr. Athar Saeed, Dr. Tabinda, Dr. Asif, Rana Hafeez, Shafi Gill, Adi Murtaza, and my own team, Chairman of the Organizing Committee, Dr. Askar Naki, Professor Aisha Shaukat, Professor Bilkis Shabir, Professor Saira Afzal, my deans, faculty member, all the speaker, ladies and gentlemen, Assalamu alaikum. On behalf of King Edward Medical University, it gives me a great pleasure to welcome all of you on third Universal Healthcare Symposium held jointly by KEMCA UK and King Edward Medical University. I am very grateful to my alumni. I think Athar Saeed has mentioned details about this symposium, but I must be thankful to the KEMCA UK for the support they are extending towards their alma mater, and they are paying back to Pakistan, to their alma mater, their support in the form of a universal and unique online critical care international multidisciplinary meeting, which are regularly being held on every Saturday. Their support in the training of the nursing program of King Edward Medical University, support in the form of PPE, support in the form of the pathology department and other department. And then we are having the unprecedented international meeting in the form of the third Universal Healthcare Symposium. And inshallah, all these guidelines will be published as in the past in the special annals of King Edward Medical University. And a few lines about the King Edward Medical University. Mashallah, we have completed 160 years of excellence in the medical education, starting from Lahore Medical School in 1860. In the current COVID pandemic, I must appreciate my government, my frontline worker, the health professionals, the way they behave. We have got attached 7 hospitals, and by the grace of Allah Almighty, not a single patient was refused from new hospital, and all the medicine they have been provided free of cost. We established the telemedicine center, where the tele outdoor facility, tele corona help desk, and tele nutritional help desk, and tele psychiatric help desk, they have been provided, supervised by the faculty, Professor Bilkis Shabir, Saqib Saeed, Department of Medicine, Department of Critical Care, and the Department of Public Health. We are having the regular original research paper, and King Edward Medical University have the honor. We have published over 100 research articles related to the COVID in the form of 3 special issues of Annals of King Edward Medical University, having the regular national and international webinar during this period, in which the Honorable Federal Minister for Health, Faisal Sultan, my very dear friend, participated, Shafkat Mahmood Saab, Professor Dr. Yasmin Rashid, Aasim Yusuf, they all have been participating in various international seminars. We contributed in the form of the guideline, the SIAG, the Corona Expert Advisory Committee. I think the main members, they are from King Edward Medical University, Professor Asad Aslam, Professor Bilkis Shabir, Saqib Saeed, Somia Iqtidar, Saira Afzal. They are contributing regularly. And I think I must appreciate, I am proud of my alumni. I am proud of Tufail. I am proud of all of you. The way you are paying back to your alma mater. और फराज के इस शेर पे मैं अपनी बात को खत्म करता हूं. फराज ने कहा था, शिकवे जुल्मत शब से तो कहीं बेहतर था अपने हिस्से की कोई शमा जलाए जाते. तो जिस अंदाज में आप शमा जला रहे हैं, We are proud of you and we are praying for you. Thank you very much, Athar Ahmed Saeed and Dr. Tufail and everybody.
Thank you very much, everybody. We're at 10 o'clock now. We're going to move to the next program very soon. Just to give you quick housekeeping rules of all the participants. All the participants on this channel will stay on it. Rest, anybody who wants to join other channels, they can go to the website because there are 3 more parallel sessions are on. There's 100 participant capacity in each channel. We have 500 capacity on this current channel. So we already have 200 people currently watching this section. Also, after this section channel close, there will be a poster section, and again we have 100 participant capacity on the poster section. So please join us. So I think with 10 o'clock we inshallah move to our next program, and I would like to introduce myself as Professor Masood Gondal has already mentioned. I'm Asif Khan. I'm your host. I'm also a consultant cardiologist at Nottinghamshire in UK. I'm working as a social secretary for KEMCA UK. I would like to introduce my first KEMCA UK co-chair, Rana Hafeez Rahman Saab, who is a consultant anesthetist in Manchester. He's also ex-chair KEMCA UK and also a trustee and of all the charitable projects in KEMCA UK. Dr. Hafeez Rahman, you're live. Thank you.
Jazakallah, Asif bhai. It's a pleasure and an honor to be co-chair for this session. And as you have already introduced myself, I'm here in Manchester at Thameside Hospital as a consultant in intensive care and anesthesia. And we have been conducting regular webinars for our teams in Mayo with the guidance of Professor Masood Gondal. So without any delay, I would like to also introduce my fellow co-chair, Professor Ijaz Hussain, who happened to be my class fellow from KE days. And he's a professor and head of Department of Dermatology. Few words from Ijaz Hussain, and then we'll introduce our first speaker.
Thank you very much, Rana Hafeez Rahman Saab. It is a great honor and pleasure to join this seminar and to be co-chair of this session. And it would be a wonderful session, as already said, very eminent person they will speak. And as part of King Edward Medical University faculty, under the guidance and supervision of Professor Khalid Masood Gondal, our very able Vice Chancellor, KEMU is progressing very much. And with the help of KEMCA UK, we hope to make further progress, inshallah. Thank you very much.
Jazakallah, Professor Ijaz. So without any further delay, I would like to introduce Professor Aasim Yusuf, who is consultant in gastroenterology and currently Chief Medical Officer at Shaukat Khanum Memorial Cancer Hospital and Research Center. And he has also helped massively in implementation of MTI reforms in KPK. He's also chair of this session. So without any further delay, I would hand over to him. He will introduce himself, and also he will be talking about health reform in KP structure, legislation, and implementation. Over to Aasim Yusuf Saab.
Thank you. I'm just going to try and share my slides. Can you see my slides?
Yes, that's fine. Thank you.
Great. Okay. Thank you very much for the introduction. I'd just like to point out I'm not a professor. I'm only a doctor. I'd like to thank Athar and the organizing committee for asking me to speak today. I've been asked to speak on the structure, legislation, and implementation regarding the healthcare reforms process in the KPK in 15 minutes. So it's going to be a bit of a whirlwind tour, I'm afraid. So I'll just start straight away. I have no financial or other disclosures, and in particular, I've received no financial compensation for work with public sector hospitals in the KPK or elsewhere. There have been previous attempts at reform. The current healthcare reform process in the KPK began in around 2014, 2015, when the the PTI government had its first provincial government in the KPK province. But prior to that, there had been other attempts at reform, in particular in the Punjab, There had been an effort to grant autonomy to hospitals, but budgets were controlled by the provincial health and finance ministries, which tended to hamstring the hospitals. And in the KPK, in a previous era, there had been an attempt to institutionalize private practice within the government hospitals by force, which led to paralysis of the healthcare system, particularly in Peshawar, and mass resignations of faculty. As a corollary, there was a massive growth in private sector facilities set up by these erstwhile faculty members. So the healthcare reform in the KPK began in 2013 to 2014 with an act to provide autonomy to the government-owned medical teaching institutions and their affiliated teaching hospitals in KPK in an effort to improve performance, enhance effectiveness, efficiency, and responsiveness for the provision of quality healthcare services to the people of the KPK. This became known as the MTI Act. In essence, the Act appointed boards of governors for each institution, and as a first step, the three major teaching hospitals in Peshawar, the Lady Reading Hospital, Khyber Teaching Hospital, and Hayatabad, as well as the Ayub Medical College and Teaching Hospital in Aptabad, were chosen as the first sites where this Act would be implemented. So each hospital got a board of governors. They were given greater financial autonomy with a one-line budget, and each MTI was to be headed by a dean, assisted by a medical director, a hospital director, and a nursing director. The functions and powers of the board were several, including ensuring that the objectives of the MTI within the overall gambit of government policy, of government policy were achieved, overseeing effective management and providing strategic direction, making policies for the MTI and ensuring that the programs were efficient and effective, prescribing the procedure for appointment of faculty and other staff, developing terms and conditions of service and disciplinary rules and so forth. Developing and helping to develop and approve a vision and mission statement for each MTI, approving the annual business plan and the budget, reviewing and approving all major transactions, financial and other, and approval of new programs and services while monitoring performance of existing programs, approving the bylaws for the medical staff and overseeing the process of appointment, constituting executive committees and other committees and subcommittees of the board as deemed necessary. And finally, compliance to government policies and standards, and in case of any deviation from agreed standards or procedures, ensuring that prior approval was obtained from the government. So what was the role of the dean? In the first iteration of the Act, the dean was just called the dean. An amendment was subsequently passed, changing that designation to dean/CEO. And the dean is overall responsible for clinical and academic quality and excellence, both in the medical school as well as in the hospital. The dean heads the academic council and heads the executive committee of the institution, in a role in which all other directors then report to him, including the hospital director, the medical director, and the finance director. The medical director was responsible for all clinical functions of the hospital, including but not limited to ensuring clinical excellence in all aspects of hospital function, ensuring timely and appropriate management of patients, ensuring best outcomes for patients, undertaking clinical governance for quality control, assessing and auditing existing clinical programs and developing new clinical programs, and developing an annual clinical budget, including the capital medical equipment requests for presentation to the hospital director and to the board. The hospital director, on the other hand, was more an administrative position, and the hospital director is responsible for all non-clinical functions of the hospital, such as security, buildings and maintenance, utilities, purchasing, and so forth. Preparation of the annual budget and the business plan for presentation and approval to the board, maintenance of building and engineering services, maintenance and development of all ancillary services, including but not limited to the pharmacy, nursing, materials management, human resources, clerical, communications, and security services. And the hospital director also acts as the principal accounting officer, responsible and accountable for maintaining financial discipline and transparency, and for implementation and execution of board policies and to achieve the targets set by the board. So it's clear that there was a dichotomy was created. The medical side on the one hand, within the hospital, was responsive to and reported to the medical director, who was overall responsible for ensuring clinical excellence in the hospital, while the hospital director was responsible for all the administrative support required to achieve such excellence. The dean, being head of the medical school, was responsible for the academic side of things, but also as the CEO oversaw the entire complex. Some common misconceptions, which really, if you read the law, should not be there, are that this is not privatization by any means. The government continues to own the institutions. The government continues to pay for them and control the budget. It's just devolving power to a more local level, devolution of power. No one lost their jobs. No one lost their accrued benefits. So at the outset, all staff were allowed to opt in or opt out of becoming institutional employees. Until the MTI Act was promulgated, most of the staff were civil servants, hired and paid for by the government. So all staff were given the option of either continuing as civil servants, which had its own set of rules, or opting to become institutional employees with the guarantee that their accrued benefits in terms of pension and so forth they would carry with them. The second opt-in and opt-out was whether to opt in to practice privately within the institution or to continue to practice elsewhere. And that's what IBP is called, institutional-based practice. There were some lacunae in the Act which required several amendments. I've mentioned one of them with regard to the role of the Dean as the CEO. Many were really procedural things that most of us didn't understand on the medical side too much, but were needed for legal and governmental purposes. But they were also amendments created in response to numerous legal challenges. And perhaps the most recent and the most significant has been the development of a policy board, which oversees the performance and function of the various boards of governors of the various institutions, which are now part of the MTI process, which number 9 now in the KPK. There has been and continues to be interference of many kinds. There's political interference with regard to appointing favored relatives, friends, supporters, and so on, with regard to promotions, fostering and supporting militancy amongst various unions, trade unions, and so on. And also there have been budget cuts. So the budget that we are supposed to get often doesn't come through in its entirety or totality because of competing demands or because of preference for one institution over another, one city over another, and so on. And there's also bureaucratic interference on many of the same sorts of things, but also because of it's commonly felt to be a feeling of being unable to let go. Government departments have lost a lot of authority. They no longer have professors coming to see them in the secretariat to get their promotions and transfers and so on sorted out. And there's also an element of employees looking back through rose-tinted spectacles and thinking that everything was so much better in the old system. We have, as boards of governors, I'm on the board at Abbottabad, we have had to stand up to the government on occasion, particularly with regard to budgetary constraints and unfair distribution of funds. I alluded to legal challenges earlier, and there have been numerous legal challenges. There were injunctions against practically everything. They're called stay orders in Pakistan. And there were injunctions sought and granted against the Act itself, which delayed its implementation for about a year. Then against the boards, the constitution of the boards, the way they were selected and so on, which again took up about 6 months before we could actually get going. And then individual decisions of the boards. Anyone is free to go to court and is usually rewarded by an injunction or a stay order. In our own particular case in Abbottabad, about 2 years ago, we were interviewing for the post of hospital director. We had shortlisted, I think, 11 candidates from a field of 50. And someone who was not shortlisted managed to get an injunction on the day of the interviews, stating that unless he was interviewed as well, the interviews could not go ahead. So, you know, it's to that level of interference. And in direct response to this, an amendment was passed to the Act, forming an appellate tribunal. so that now all employees or anyone aggrieved of anything happening at a medical teaching institution in the Khyber Pakhtunkhwa can no longer go straight to court. They have to go first to the appellate tribunal. And if the appellate tribunal rules against them, then they may appeal to a higher authority. And we'll come to that in a second. So the appellate tribunal has 6 members, each of whom have a 5-year term. They're all retired judges of the High Court or the Supreme Court, or senior advocates of the Supreme Court with, I think, 25 years of experience of litigation. Appointments are based on recommendations of the Federal Ministry of Law and the Attorney General of Pakistan. And an appeal against the final judgment of the tribunal can only be made to the Supreme Court of Pakistan. So we hope that this will streamline this process of injunctions and stay orders and lead to greater opportunities to actually implement the changes that are proposed without necessarily limiting the rights of those who wish to litigate. In parallel, there have been efforts to improve primary and secondary healthcare, again in the KPK, which really has started more or less at the same time. A bill was passed in 2019 to construct and regulate healthcare facilities in the province of the KPK. This was called the Regional Health Authority Bill.
12 minutes time check.
Okay. The policy board is shown here. The policy board develops base standards, establishes minimum qualifications required, and reviews the annual reports of each regional health authority. And a regional health authority is constituted of senior doctors, a senior
Can we hear okay?
No, you cannot hear.
Dr. Aasim Yusuf, we have lost the signals from your side.
I think we should wait. It should come back. It must be a connectivity problem.
Let's see if we can reconnect because I think he's trying to reconnect. While we're waiting, Dr. Hafeez Rahman Sahab, do you have any comments so far?
I think it's going nicely. I mean, while obviously we are, what I can see from so far, what obviously Dr. Aasim has presented, to me, it looks like similar to what we practice in NHS in UK and probably in Ireland as well. So which seems to have worked. I mean, working in the NHS, we do see that it's probably from the patient's welfare perspective, it's one of the best systems in the world. And so it will be nice if we can implement the same practice in Pakistan. I can imagine there will be glitches on the road, and obviously government and obviously professionals have to iron those out as we go along. And hopefully in due course of time, we should have a service which is
okay.
I think Aasim
Aasim is back. So, yeah.
So I will hand over back to him.
You can unmute yourself, Aasim. Thank you. Sorry.
Right, sorry about that. Power cut. For those of you in England who've forgotten what that's like. So anyway, so I was talking about the composition of the Regional Health Authority. We've lost some time, I'm afraid. And then there are district health authorities under the Regional Health Authority who report to the Regional Health Authority, each of whom is headed by a CEO and are responsible for all public health facilities within the district. Each district hospital has a hospital director, medical director, and a nursing director, similar to the structure of the MTI. Other acts have also been passed, one regulating the DIB and homeopathic facilities, a Mental Health Act in 2017, which I'm not really going to go into in detail now. And a very important one, a blood transfusion safety authority has been enacted, and regional blood transfusion centers are in the process of being constructed in Peshawar and in Abbottabad at the current time. And then finally, the Khyber Pakhtunkhwa Faculty of Paramedical and Allied Health Sciences Act, also in 2016. So, is it all doom and gloom? Has nothing worked? No, not far from it. Hospital information systems have been developed, and they're all on the same system. There's been considerable investment into infrastructure, rehabilitation, and in new equipment. Salaries and career structures have been improved. Institutional-based practice has been patchy, but it's taking off slowly. Patient and bed management systems have been implemented, and there are many other individual achievements. What we've learned is that it's very important to get the right people on the bus. In our own example in Abbottabad, we've changed the top management 2 or 3 times, but now for the last 2 years or so, have got a somewhat more stable team. It is very important that you have the right people for the job. Emphasizing the need to undertake high-impact, low-cost initiatives or high-impact, high-cost initiatives, but avoiding low-impact and high-cost ones. And most importantly, to persevere. It's not going to happen overnight. With challenges coming in the Punjab in the near future, this will be a very important thing, I think. The reforms process represents a sincere and determined effort to bring about improvement by radically altering the structure of the healthcare institutions. It's not necessarily the best way to do it, and it's certainly not the only way, but it is something now that we've got considerable experience of and that we've learned through the vicissitudes of time how to fix and implement. And we do believe that working together, we can improve healthcare provision for everyone in this country. Thank you. Stop sharing.
Thank you very much.
Thank you very much, Aasim Yusuf, for a wonderful presentation and to give us an overview of how MTI was implemented in KPK and how we will be taking it forward in Punjab. And
one question.
I have been keeping an eye on Q&A, and there have been one question about how does MTI will affect the delivery of service to
government
patients?
hospitals. Yeah.
And there are then a couple of questions my co-chair, Professor Ijaz, has already prepared for you. So let's see first one.
I'll take this one first. Yeah.
So,
so I mean, ideally, the point is that MTI is meant to improve the quality of care that is delivered. And so that can only be beneficial for patients. In practical terms, what it means, for instance, is that faculty are more likely to be present because, for instance, attendance systems were implemented. There is more of a culture of accountability. Clinical audit occurs. So, all these are measures which will improve the care delivery to patients. Secondly, through institution-based practice, what we've tried to implement is a structure where the consultants are more willing to see their private patients in the hospital. And as we know, that has a twofold benefit. First of all, it creates revenue for the hospital, which is plowed back into the system. But more importantly, it improves the overall quality of the institution because consultants and professors and leaders in the institution then have a vested interest in improving services within the hospital, because otherwise their private patients won't want to come and be treated there. And then those facilities are available to all the patients.
Professor Ijaz, you wanted to ask a question of if you can unmute yourself?
Yes, sir. There was a question that what will be the mechanism of promotion of teaching staff who are already working in the institution if they join MTI? Say like in government service, after a few years, say like when you work for 5 years as assistant professor, you are promoted as associate professor. After MTI, would there be automatic promotions or they will have to appear each time for new post?
Yeah, so
help.
Right. So the entire process of appointments and promotions is laid out in the regulations for the institution. And they may vary slightly from one to another. But the basic principles are that there is no such thing as automatic promotion. You are appointed at one level and you compete for promotion to the next level with other people within your institution and from those who may apply from elsewhere. and the best person will be appointed to that position. A number of criteria will be taken into consideration: your performance, your appraisals, your research productivity, since these are academic appointments by and large, your audit, the audit of your clinical results, and so on. All this will be taken into consideration. There is a time limitation in the sense that if you've been in a position for a particular number of years, it varies from one to another, then you are required to be considered for promotion after a certain period of time. If you don't get it, you don't get it, but there will be a time limit beyond which you cannot continue without being considered for promotion.
Then there was, sir, an other question that if we intend to start institution-based practice, do you think that required for institution-based practice is ready in government sector hospitals, say like in terms of seating arrangement, clinics, which are at par with the private hospitals, say like in Lahore, National Defense.
Yeah. Okay. So first of all, I mean, my talk is about the KPK primarily. So I think others are going to speak about the Punjab in particular. But it's a case of the chicken, which came first, the chicken or the egg. If we wait forever for the institution to be equivalent to some, very nice private hospital in Lahore or Peshawar or somewhere, that may take decades. I don't know when that will happen. What we feel is that doing it the other way around, asking people to practice, improving the facility as we go on. We provide a certain basic standard, of course. But then the funds that you generate from IBP can be plowed back into the system to develop the facilities further. And that's how it will continue to improve. If we wait forever for this sort of nirvana-like state where everything will be ideal before we start practicing, who knows when that will happen? And in the KPK, I know the facilities that people practice in privately are very variable. They're not all, plush and 5-star facilities. Some of them are very, very basic. And certainly the government hospitals provide much better facilities than many of those.
Many thanks. Can I ask a couple of questions? I mean, I think when you switched off because of power cutout, I did discuss that what obviously MTI is, it looks almost similar to what NHS is. And we do not necessarily have got a hierarchical system in NHS. And I can see the similarities in MTI. So you can have a junior person be appointed as a clinical lead or head of the department, and it works perfectly fine. So I can vouch from working in the NHS that it is not really a failed system, and it has worked in NHS. So I would expect the same questions were asked actually on the Q&A.
Yes.
The couple of questions I would put to you, that what is the impact so far in the last 7 years the MTI has shown? And the second one was, which I have tried to answer, that sometimes the juniors are appointed at senior posts or so-called senior posts, and that sometimes creates a bit of disharmony. How we are going to sort of really make people understand that the structure is not hierarchical and it is on capability based.
Yeah, I think, you've hit the core of the problem here, that the system has traditionally been based simply on seniority, number of years in post, and just natural progression, as Dr. Ijaz was also mentioning, from one level to the next based on number of years spent. We don't think that that is necessarily the best way to do it. There isn't necessarily a rule or a move that all positions must be filled by junior faculty. That is not the case. In our own example in Aptabad, for instance, we've had senior professors heading most clinical departments. Only recently, when we finally put the IBP question to our faculty, those who opt out, one of the provisions of the regulations requires that if you opt out of institutional-based practice or of becoming an institution employee, then you cannot occupy positions such as chairing a department, being a department head, and so on. So there, you have to then appoint someone else. And again, there isn't a requirement that it be the most junior person there. It'll be the next senior most usually. It would be very unusual that you appoint someone fresh out of training to head a clinical department.
I think we can start the next talk. Hafeez bhai, you're on mute.
Yeah, I'm.
Hafeez bhai, you're on mute, sir. Thank you.
Yeah, there have been some questions on Q&A. We will obviously try to answer on the chat section. But we will obviously move on to our next speaker. Professor Ijaz, if you can unmute yourself and introduce our next speaker, please.
Next speaker is Dr. Obaidullah.
Yes. Shall I start?
Sir, I will request you to please give us.
Yeah. I'm professor of plastic surgery in Northwest General Hospital. I started my work in Leading Hospital, then moved to Hyderabad Medical Complex, and was one of those mass resignations in 2002. I'm basically trained in UK, United States, and Canada. I have a private practice now in Northwest General Hospital. I'm a social worker. I write for a few newspapers as well. I present on TVs for public education, just public health education. I had a large contribution in the last IBP quagmire in 2002. So that's why probably they invited me. I have a presentation. Can I share my screen then?
You can share screen from your
Yeah. I'm trying to find out. Just a moment. Just a moment.
So if you have PowerPoint already open, then you'll be able to do that.
Yeah, the PowerPoint is open now.
You have to press the share screen and then click on PowerPoint and press share again. So share screen first. So there's an option on the bottom says share screen. When you click on that, then you click on your PowerPoint and then press share again.
Yes, yes, here it is.
Perfect.
Right.
Thank you. You can do the slideshow.
Yes, yeah.
Thank you.
Okay. Right. Health reforms is not something which is new. There's a bit of history of health reforms. President Truman started in USA soon after Second World War, and he intended that every citizen, every American citizen should have access to free medical care. However, he could not provide a universal health care, though he was able to make many more hospitals in the United States. Eisenhower later restricted access to medical care and emphasized more on marine hospitals. The debate still goes on in American administration as to what extent healthcare should be provided to the public. There is a serious conflict of interest among the stakeholders like American Medical Association and insurance firms. These have made American model of healthcare extremely expensive. Europe relatively superseded USA in developing their healthcare system, first in Germany under Bismarck and then in UK under Churchill. In the civilized countries, goals and objectives of every reforms are sorted out first. However, for the last 70 years, we haven't been able to focus on the type of reform or the area to be implemented. Most reforms introduced into healthcare system have been by those who look at healthcare as an administrative domain only. However, the reality shows that healthcare covers three most important aspects of our daily life: clinical, academic, and the last comes administrative and the financial aspects. Healthcare industry has always been mesmerized by the airline industry. for its safety. The latter is indeed the safest in industry. In 2018, the rate of major jet accidents measured in jet hull losses per 1 million flights was 0.19, which was equivalent to one major accident for every 5.5 million flights. Generally, there is one incidence reporting when 45 million passengers travel for more than 800 kilometers. There is one reported fatality if 70 million passengers travel for more than 800 kilometers. The airline industry has put a lot of efforts in not only regulating their staff, but have a regular staff training, but also developing standard operating procedures. It is this checklist before takeoff that makes flights so safe. Now consider these standards with the healthcare in the most advanced country in the world, where 200 preventable deaths occur every year in USA. 98,000 of these are prescription related. So how could we emulate airline industry safety? By guidelines. Clinical guidelines, first of all, started in 1960, but actually got momentum in the 90s. So what happens when we do not have uniform guidelines across the country and across the health sector? Polypharmacy, self-medication, drug interaction, and high complication rate are the few casualties we suffer. Our primary health care and hospitals have no link with each other. Then comes the bed management. I will not go into the details of it because it's beyond the scope of this presentation. At the moment, there is very little uniformity in the training of residents across various hospitals. Training should be in the highest priority of the government in not only public hospitals, but also private institutions. For this purpose, the clinical protocols or guidelines are absolutely essential to bring not only training, but also patient care to a uniform level. Once these guidelines are in place, training of all categories of healthcare workers become a smooth sailing process. Everyone in the ward knows the exact drill for each admission and management. In a way, the training goes to a higher level of automation. This can bring down the cost of hospital tremendously. For example, only establishing a local formulary in the health department, this would reduce the inventory to only 1/5 of the present one. And prices can be negotiated with pharmaceuticals for bulk purchases. The administrative and financial reforms have always been a priority for the policymakers. However, as elsewhere, bureaucracy becomes a stumbling block, as Aasim had mentioned earlier. The problem with bureaucracy is that it keeps on growing faster than the development of the institute. So in a way, bureaucracy begets bureaucracy. Soon after appointment of an administrator in one area of the institute, you find a bigger number of administrators in the next session. Look at the government department level. We used to have a secretary, a couple of deputy secretaries, and as many pairs of section officers in each department. And now we have a regular secretary, a couple of additional secretaries, then an army of special secretaries, perhaps twice as many deputy secretaries, each with a team of 4 or 5 section officers. What do? They approve, sign, and cross off immediate subordinate paras, change spellings, and add grammar. Even the cheapest computer can do that. You know, every the workforce, a lean workforce is always a better managed one. Everyone knows where the buck stops. With a large bureaucracy, you don't know where the buck stops. Richard Branson has been a pioneer in Britain and is a billionaire. And his famous quote is that clients don't come first, employees come first. If you take care of the employees, then they will take care of your customers. Now, There are stakeholders in MTIs. Patients are the first, but they don't have any say in changing the system. There is no scheme of things to train the patients. Patients facilitation is the greatest requirement for the number of patients merely coming to lady reading hospital. 5,000 patients visit their ER every day. Healthcare workers are the largest stakeholders in any country. 4 out of 10 jobs globally are health related. Dealing with such a large staff has to be very professional. You all know the burnout is the highest among the healthcare workers. Suicide rate is even higher than in the general public. I have gone through the same process during my training in lead reading hospital. I hardly remember eating on time or having access to healthy food. Nurses are the worst hit. A 70-bed ward used to be run by 2 nurses. If they were superwomen and could work 4 times faster, even then they could not give all the 70 patients medications twice at night, take their vitals, and attend to their pain relief. Administrative staff, on the other hand, nearly always side with the rowdy attendants. There is very little protection of healthcare workers. The administrators have their own stake, but they are in a position to do anything they want. However, the society in general can be said to be the largest stakeholder in the public sector, health system. Very little has been done to educate the public. The hospital services are neither projected in the public nor appreciated or the approach explained. When the idea of MTI or similar one emerged in the early 80s, every time a strong man became executive in the province, one form or the other form of reform was tried to be shoved down the healthcare workers' throats. All those reforms failed, and at times chaos erupted. The main reason was not taking into confidence the pillars supposed to support the new law. In 2002, the military government was adamant about IBP and ended up in mass resignation of experienced staff. I was one of them. I'm glad that I decided to leave. However, it's an irony that I had refused to share my private practice with the government then. Now I'm sharing it with a private institute. Looking 18 years back, I know that IBP idea is a brilliant one, only if the stakeholders were taken into confidence. We must look into the healthcare system of KP. The healthcare culture, the health culture of KP is entirely different from other provinces. If you compare the pharmaceutical sale of Peshawar, it is twice as much as Lahore's. My dear colleagues, Pakhtuns would sell their property but would take their near and dear ones to private care. That is why Shifa International has more than 60% patients speaking Pashto. Same goes with Aga Khan Hospital in Karachi. However, patients of this province would like to be attached to one consultant. It doesn't matter where the consultant is available. Now, if it comes to the riddle, who's the first, chicken or the egg? Most consultants made their impact while working in these large teaching hospitals. They went through a process of promotions to become professors. LRH is my alma mater. I made a name there. I now practice from 7:30 in the morning to 12 midday. Believe me, there are patients waiting for me when I enter my clinic. So it doesn't matter where I sit, at what time I start. My patients are loyal patients. And this is throughout the KP. So it comes to senior, renowned, and experienced consultants who would attract patients. If they want to sit in the hospital for private practice, patients would not mind spending their nights in the open for them. With MTI reforms, this point was not considered at all. The benefits are tremendous of the IBP, but they have to be for example, the healthcare workers are available 24/7 as against private medical institutions. There are few obstacles. Pakistan in general and KP in particular has a lack of human resource. Professionalism is at its lowest ebb. Peep into any government office and you could hardly find any high official coming on time. Most of the bureaucrats stay in their offices for longer time, but without showing any output. Medics, on the other hand, rush to their private clinics at the earliest possibility. You can also observe that most of the social gatherings are held in the official times. As a principle, all government officials are required to undergo training sessions before the start of their official work as well as during their service. Last year, a training session was made for a few doctors, most of whom were going to retire in 2 to 3 months' time. So the health department could hardly cope with the demand of trained human resource. When the FTI Act came, let all the teaching hospitals loose without any oversight from the health department. As salaries were lucrative for the administrative jobs, the health department got depleted of these trained personnel within no time. Now came the dilemma. The health department was without trained human resource. MTI is kept on increasing in the number of and poaching on all the capable administrative staff. Soon there was a rush to get short-term, fast-track administrative diplomas, and thus staff with very little practical experience was the only kind of people available to the MTIs. The latter were handed over to the Board of Governors. These boards were of an entirely different and diverse background. Very few of them had any experience of the health administration. In turn, they had to depend on few wise men within the institutions. Here came the actual damage. Most capable medical personnel would avoid proximity to administration and would rather spend time in patient care and education. Those without these qualities thus became the ears and eyes of the Board of Governors. What a loss. LRH in particular lost all capable healthcare professionals who gave this institution its name.
12 minutes time check.
Right. I'm just finishing. The whole healthcare system needs an overhaul. This is a long-term mission, and another symposium perhaps could be organized at times. The previous IBP model failed because the government did not improve the hospital facilities for the general public. So we have to make a model hospital first for the general public, at least increase the facilities and the cleanliness and an appointment system. And the patients will definitely be attracted. Once they gain confidence, a private block can then become a gold mine for the hospital. But egg is the first. Thank you.
Thank you very much, Professor Obaidullah. It was a very interesting talk. And so while I'm waiting for Q&A to be filled with more questions, I would put some questions to you.
Yes.
I mean, what I can see in UK, we have got a health budget of 120 billion pounds.
Yes.
And if we compare that in Pakistan, that probably will be pennies.
Yes.
So how you see that we can meet the same expectation in Pakistan, because obviously our aim is definitely to provide a healthcare service to our patients. In NHS, we have the motto that health service for all at the point of care, free of charge. Do you think that is possible in Pakistan? If not, what is the alternate?
Number one, the best thing PTI government has started is the health insurance. That is the best way to do it. Number one. Number two, money has never been a problem in Pakistan. It's the misappropriation of the funds. In equipment, for example, in a CT scanner, which can be easily purchased for 15 million rupees in the open market, is sold to a government hospital for something like 40 million. And this is happening every day. And who does that? The administration, because the clinicians don't have any say in it. The in 1997, I was the Secretary of Health was trying to make new hospitals, and he didn't have any funds. And I told him, I met him, we had a meeting, and I told him, why don't you make an inventory of your whole health department? And you will be astonished to see redundant equipment lying in places where there is no user. For example, in Landi Kotal Hospital, there were 3 doctors, and they had a full video, gastroscope and endoscope, the whole system. I mean, from colonoscopy to gastroscopy. That's what's lying there.
Sure. Thank you very much. I think, yeah, that gives us an idea that hopefully with bringing the bureaucratic system out, leaving it out and bringing it local governance will hopefully iron out these things. So may I ask Professor Ijaz to present one question, and after that, I think we'll move on to our next speaker because we are running a bit short of time.
Sir, I will ask Dr. Obaidullah Sahab if he gets a chance, would like to join MTI, which is being practiced in KPK nowadays, because he has seen both sides of the picture. He is currently in private practice, and before he had been serving in the public sector hospital. What is his experience?
I'll give you the actual scenario which happened a few months back. I was offered to become the medical director of one of the hospitals, one of the teaching hospitals. And they actually doubled the salary for me. But when I went into the hospital, I saw the politicization of the, and there were lots of problems, same administrative problems. And I thought at this age, I couldn't cope with the politics of the administrators in that hospital. So I refused, but I will if there is an MTI. When I started I was the first plastic surgeon of KP, and when we started plastic surgery unit in 1997, it was recognized by CPSP, and since then our infection rate has been 0.6%. This is just one audit.
Thank you very much. I would, sorry to interrupt again. As we are running short of time, thank you very much. I mean, I can see that there are obviously, even in UK, there are consultants who do not join NHS. So it's not uncommon that people do have choices, and MTI brings this choice, and hopefully people will see it as a positive for the provision of health service for our patients. But yes, I mean, there will be some people who won't join. So definitely that choice should be there. So with that, I would conclude this talk, and I would like to invite our next speaker, who is no other than Dr. Yasmin Rashid.
Dr. Hafeez, Dr. Yasmin Rashid is unable to attend this session. She will join in the next session. So I think we should move to Dr. Faisal Sultan. If he can join, Dr. Faisal Sultan is available in our panelist list at the moment.
Okay. That's very kind. Thank you very much. Thanks for, we can obviously bring Yasmin Rashid later. So our next speaker is Dr. Faisal Sultan, who is Diplomat, American Board of Internal Medicine and Infectious Diseases, and he's currently Chief Executive Officer at Shaukat Khanum Hospital and Consultant Physician, Medicine and Infectious Diseases. And he's also has the honor of Special Assistant to the Prime Minister on Health Services in Pakistan. So he will be talking in favor of the debate For the MTI Act ensures physician job security and improves service delivery. Dr. Faisal Sultan, please.
Okay, I assume you can see my slides. So, Assalamu alaikum. Thank you, everybody.
Yes, you're okay.
Okay. So, first things first, correction. I'm not the Chief Executive Officer of Shaukat Khanum. I was. So, I could not do both things all at the same time. So, therefore, I stepped down. And my current position, as you mentioned, is as Special Assistant to the Prime Minister on Health. So what I'm going to talk about in the next few minutes is an assertion that MTI reforms improve service, and really the purpose, nature, and impact of large healthcare organizations, also known as the Medical Teaching Institutes Act. I'd like to start off by Allama Iqbal. And Jahan taza ki afkar taza se hai namood ke sango khisht se hote nahi jahan paida. Everything new that comes is from new ideas. Jahan taza ki afkar taza, and not from brick and mortar. And this is fundamentally about how we look at reform in the large teaching hospitals. Now, one of the most important perspective of this is from the end user's point of view. And as far as the end user is concerned, there has been status quo for too long. The expectation is of high quality of service, dignity of treatment, and free at the point of care. But the reality is that the quality is poor, there is understaffing, under-equipped organizations, underfunded, and generally low accountability for anything really. And the free in many things is in theory only. So where do we go from here? So salient features of this reform include fundamentally change in the governance structure. What's in place and is being proposed for newer hospitals is a board of governors for each hospital. So you bring closer to the hospital its governance instead of the hospital's chief executive or executive director or MS or whatever you call it, reporting to some secretary, and then in turn, in reality, to a joint secretary or an additional or a special secretary who changes every few months. There is no institutional memory and so on. And so therefore, this aims to bring a certain stability, ownership, and it includes 3 to 7 experts from the private sector for a renewable term of 3 years. And there is some variation in this. But these people are accountable to the government because they are appointed by the government. What they're responsible for is very simple stuff. Strategic direction and policy making, overseeing of management, not doing it themselves. That's very crucial. It's very difficult to do sometimes to maintain this gap. There is a temptation to overreach. But this is something that even the governing boards have had to learn with time. This is nothing new. It is simple on paper, but sometimes difficult to do. And of course, they have to ensure that the government's targets are met. In terms of finance, they have to look and approve the annual budget and major transactions, monitor the major programs' performance, and approve new programs and ensure compliance. And of course, as far as HR is concerned, really, they prescribe procedures via regulations and they restructure positions, and they're not supposed to exceed the total budget, but to live within it. Now, in terms of management, that was governance. Now this is management. And you will see, and I'll show you a slide, why this differs very significantly from what is practiced currently. What's envisioned is a dean of a medical school or a dental school who's the chairman. There is a hospital director who fundamentally administers the non-clinical functions of the hospital, a medical director that administers fundamentally the clinical functions of the hospital and clinical governance, a nursing director. And this is nearly revolutionary because generally we've not allowed our nursing sector to grow or to stand at the same level or place as other professionals. A finance director and 1 or 2 recommendations in addition from the dean. This becomes the management committees. The civil servants currently serving would choose to remain either as civil servants and continue working or transition into being an employee of the MTI. Newer hirings, of course, envision only institutional employees unless the board requires a deputation from the health department. Now, this is the structure that is in the MTI, as opposed to the structure that I've put out. And this is for PIMS, but really many similar confusing, overlapping, and non-modern structures exist to manage hospitals. There's a lot of concentration of authority, and civil servants, of course, are the governing entity, and some of them end up serving in the organization as well. There is frequent movement, very little institutional knowledge. And so really a lack of input sometimes of very important people into the administrative and leadership functions of the hospital. There's been a lot of talk about institution-based practice. This is not easy to implement properly. It's a tough one. The concept is good, but it requires some effort and some work. All new employees must conduct private practice. That means those that are allowed to practice. The existing people may opt in or opt out, and the incentives are very clear. Especially if you're a new joiner, you have low overheads. You may be provided higher volume of patients because of the fact that it's a large, busy hospital. You do retain 100% of the professional fee, and the institutional charges, of course, can be distributed amongst employees. Now, there are safeguards and benefits for patients. So it's free for non-paying patients who are unable to afford. This is one of the things that many of the, I would say, dishonest opponents of the idea try to pitch forth as if these organizations will become privatized. They're not being privatized. They are being just altered in the way they are managed and governed. Of course, charges for even paying patients would have to bear relevance to reality and so on. Now, the other important intervention of this reform is funding, which is that even today the government gives a budget, but it is locked into various heads, and you cannot change it without referring back to the government, and which creates a long loop and very difficult to manage. So here the board allocates a single one-line budget. And of course, additionally, the hospital or the institution can create some funding through receipts and user charges as specified by the board and the government. Some of which would come from IBP and so on. If there is ever a surplus, I can't imagine that for a long time we would have any surpluses in our hospitals because they require inflow of money rather than anything else. But if there was one, you could invest it and actually create an endowment or create a perpetual source of income for the institution. And obviously rigorous auditing. So there is the government audit, but in addition, there are envisioned audits by auditors hired by the institution itself. So the salient features are this governance by reputed technocrats. There is better integration, it's more nuanced, and of course the reporting is to the government. The devolution is by management committee, and of course it's broader, it's not a single person. There is of course a head of the MC, but there are other people who sit on the table and bring this collective wisdom to make decisions. There are staggered replacements of civil servants, as I mentioned, single line budget I mentioned, fundraising. A lot of units in our public sector hospitals by very committed, hardworking professionals who reach out to their contacts and donors and bring in money. But that's done in a piecemeal fashion, and here and there a ward is upgraded, a machine is bought. But this could be all brought into a central focus and would work much better perhaps instead of a reactive piecemeal fundraising that people do. I've mentioned institution-based practice, and this would hopefully attract better talent. People like my previous speaker who are at the far end, at the top end of their practice, may not find it very easy to switch back to this situation, but there are people who are still building their practices and would indeed be the future such top-end professionals. The people say, okay, so what? That's on paper. What have you done? What has happened? I'll give you a few examples. And I've chosen about 5 or 6 slides from nearly 60. It was a hard decision to choose what to put out, but a few more specific examples of what all did happen. And this is only a 2-year time frame at Khyber Teaching. People said, well, people will not come, poor people will not come, how will you manage? So the workload went up. It went from 496,000 to 633, and no evening and night shifts, please mind it. It is common to go to public sector hospitals. You cannot find an inch of space in the morning, and you come after 2:30, 2 p.m. and you can play cricket in the halls sometimes because they are poorly managed spaces. And so this was changed. Again, the casualty went down, but it was this depressurizing into the non-real casualty into other areas. Institution-based practice was started. And so it had its jumps and starts, it had its movements both ways, but at the end, it is there and for something to be built. Services and specialties. We had dynamic bed allocation now. Previous to this, you could have one part of the hospital where you had 2 persons on a bed, and on another part of the hospital which had empty beds. So this dynamic allocation was brought in, and despite 95% occupancy, there were no patients lying on the floors. The only exception to this was, I think, pediatrics, which requires some special intervention. Theaters and diagnostic facilities would stop at 2 p.m. They went 24/7. Physical availability of teaching and technical staff was available for much longer hours, at least 14 perhaps, because of IBP. Hospital revenue went up. Cash handling, financial discipline improved as well. HR, again, I just put out a few things here. The bottom line is this: these things do not improve or change in a day. When we have poorly invested into people, into finances, into systems for decade after decade, we cannot say, well, change in a day. Ye sarson hatheli pe nahi jamti, lekin आईने नौ से डरना, तर्जे कोहन पे अड़ना, मंजिल यही कठन है कौमों की जिंदगी में. And the next one is even more important, and it's something for us to bear attention to. ये कारवान हस्ती है तेज गाम ऐसा, कौमें कुचल गई हैं जिसकी राह रवी में. If you don't move with the times, you become irrelevant. I'll stop here. Thank you very much.
Jazakallah, Faisal Sultan. It was a very interesting and informative talk. I must say, I enjoyed it thoroughly, and I hope our viewers have done the same. Working in the NHS, I do always try to run parallels and compare our practice, and obviously look at how MTI will be looking like NHS in due course. And I can see, and few comments to make really, like we look in NHS that we also ask that same question, that the resources like CT, MRI, or other equipment, they're built to work 24 hours, just like aeroplanes. But sometimes we only use 8 to 5 in UK, and in Pakistan, 8 to 2. So why can't we have services developed in a way that obviously these resources are used around the clock, or at least for maximum time of the day? So which you have highlighted that obviously that effort is being made. So hopefully that will help a lot. Then a couple of questions I would like to ask, that how we engage the patients and staff. Are there any processes to get patient feedback surveys or consultation with staff before we implement things? In UK, we have got this process of having consultations, which government initiates, which supposedly an MTI or a local MTI can do the same, that they introduce a consultation. In the end, obviously the Board of Governors or government will take the comments into consideration. Not necessarily every comment will obviously change the practice, but at least the different views will be taken on board. So how do you think, that will help?
Okay, so I'll tell you the experience at Khyber Teaching, where I served for a number of years. Again, from there as well, I stepped down in August and had taken really leave in March. But nearly 4 years, perhaps a little over, I served there. And as an example of the consultation that was done for regulations, I'll tell you that we took 6 months of consultation with literally every stakeholder that was there. And the regulations that got signed off had, I would say, a 99% or perhaps even a 99.9% acceptance from all the stakeholders. We had active consultations with the chair of the Teacher Staff Association, the Professor Staff Association, as well as with what very poorly are called the class 4 servants. I hate that word, but the non-physician workers of the hospital. So what was done was an extensive process of consultation in framing those regulations. In terms of patient feedback, you will be delighted to know that when the process was done at Khyber, through the help of the KP Health Commission and who in turn engaged professional surveyors from Shifa, I think, a baseline and 2 additional surveys were done over a 2-year time frame or a 1.5-year time frame. An audit survey is literally a very watered down version of what would be the Joint Commission or a similar survey. And those were done at baseline and then after a gap and then yet another after gap. And we were given the dashboards and compared ourselves to other institutions. So Khyber was compared to HMC and to Lady Reading. And so we had these red, blue, green dots, which showed us whether we were moving along in time or not. So I think these organizations need to remain accountable at all levels, all the way from governing entities down to the last person that serves there. And I think that's the only way to be able to engage with the public. New departments of quality assurance and complaint handling were set up. Again, responsive to the needs of the public. So there, in addition to many other functional departments that were set up that didn't exist.
Thank you, Faisal. Abhi, stay here. I have been reminded that because it's a debate, I would need to ask Professor Ijaz to get our second speaker who will be talking against this topic of the MTI Act ensures physician job. So Professor Ijaz, if you can kindly introduce our next speaker.
Thank you, sir. Now I would invite Professor Mohammed Nizami. He is renowned orthopedic surgeon of Lahore, and he is President Pakistan Medical Association of Punjab, and he will talk against the MTI reforms in which government is planning. Professor Mohammed Ashraf Nizami.
Thank you very much, Dr. Ijaz. Thank you very much, the honorable organizers. You have invited me, given this privilege and respect to the Medical Association, to give our point of view on the MTI Act or MTI change. Firstly, मैं एक तो मुबारकबाद देना चाहूँगा अपने दोस्त फैसल को कि उन्होंने अल्लामा इकबाल के साथ जो किया. So I will have a privilege to speak in उर्दू अल्लामा इकबाल की जो थी और प्लस उसके साथ जो कि इंग्लिश में भी, if it is I'm not wrong, कि हमारे जो ऑडियंस है उनमें कोई भी ऐसा नहीं है जो कि सिर्फ अंग्रेजी के अलावा कोई जुबान ना समझता. So my all respect to the language, and I hope that the organizers will not mind if I speak in Urdu too. एक तो मैं शुक्रिया अदा करना चाहूँगा कि केमका यूके ने वो काम किया जो हम समझते हैं एज पाकिस्तान मेडिकल एसोसिएशन के ये काम हुकूमत के करने थे. अभी मेरे दोस्त डॉक्टर फैसल सुल्तान ने जैसे कहा कि उन्होंने स्टेक होल्डर से केपीके के अंदर बातें की, लाहौर के अंदर भी हुआ, और हमने भी यही चाहा कि इसके साथ अगर ये स्टेक होल्डर्स इज वेरी मच क्लियर कि उसके साथ हमारे मरीज हैं, मरीज मीन बाय द सोसाइटी, उसके साथ हमारे हेल्थ प्रोफेशनल्स हैं, हेल्थ प्रोफेशनल या सर्विस प्रोवाइडर्स जो हैं, और सर्टेनली द एडमिनिस्ट्रेशन, एंड वी कैन से इट इज द गवर्नमेंट. एक बड़ा अजीब सा हमारे साथ एक हादसा है कि हम कुछ चीज़ें कहते हैं, करना चाहते हैं और इम्प्रूवमेंट की खातिर चीज़ें चाहेंगे. मेरे तीनों दोस्त जो अभी तक मतलब इस बारे में बात कर चुके हैं, और डॉक्टर उबैद साहब ने, प्रोफेसर उबैद साहब ने पेशावर से जो बात की और उन्होंने जो बताया, और इन सब का जो एक लब्बे लुबाब, और अगर मैं एक सेंटेंस में करूं, दैट ऑल इज अबाउट द एडमिनिस्ट्रेशन, कि एडमिनिस्ट्रेटिव फेलियर की वजह से ये समझते हैं कि यहाँ पे कोई ना कोई चीज करने की जरूरत है, एंड दैट नीड्स. आई एग्री. मैं एक चीज आपसे एक थोड़ा सा, ताकि हम एक पेज के ऊपर आ जाएं, और मेरी अंडरस्टैंडिंग ऑफ पाकिस्तान मेडिकल एसोसिएशन ये कि हम इसके खिलाफ है, नथिंग डूइंग, ऐसी बात नहीं है. वी आर फॉर द गुड सर्विसेज, वी आर फॉर द बेटरमेंट ऑफ हेल्थ सर्विसेज. एक चीज मैं अर्ज करता जाऊं कि कोविड-19 के हवाले से जो एक हमारे साथ आई है ये वबा आलमी तौर पे, ये मेरा मानना है कि कोविड-19 हैज नॉट डिस्ट्रॉयड द सिस्टम, बट इट हैज एक्सपोज्ड द डिस्ट्रॉयड सिस्टम्स. और अनफॉर्चुनेटली ये जो चीजें दुनिया के अंदर आ रही हैं और हेल्थ सिस्टम के साथ जो चीजें आ रही हैं, उनके अंदर भी दैट स्टैंड्स ट्रू. I do agree, मैं कतई तौर पे इसके खिलाफ नहीं है कि चेंजेस जो हैं, एंड देयर इज कि हर बाशऊर आदमी ये समझता है चेंज फॉर द इम्प्रूवमेंट इन एनी सिस्टम इज essential, very much essential, and it is a continuous process. लेकिन साथ ही साथ मेरा ये मानना भी है change for the sake of change, क्योंकि हम आए हैं एक पॉलिटिकल स्लोगन्स के साथ आके और हम करना चाहें, वो मैं समझता हूं कि वो एक गैर जरूरी है. Why I'm saying this? कि this MTI जिसको कहा जाता है कि एक ऑटोनॉमी होएगी, इंडिपेंडेंस आ जाएगी, it is not a new phenomena. पंजाब के अंदर एटलीस्ट इट इज नॉट न्यू फिनोमिना. अगर देखें तो पहले हुकूमत थी, विच वाज दी हुकूमत, अगर बाई नेम मुझे इजाजत दें तो परवेज मुशर्रफ साहब की हुकूमत थी. उन्होंने यहाँ पे ऑटोनॉमी की और लाहौर जनरल हॉस्पिटल के अंदर पहली डॉक्टर सबिया शकील गालिबन, उनको वहां पे एडमिनिस्ट्रेटर लगाया गया और फिर बोर्ड ऑफ गवर्नर्स, बोर्ड ऑफ मैनेजमेंट और ये सारी चीज की गई. बट दैट वाज अ फेलियर. द रीजन बीइंग कि autonomy at the center and satisfaction of the health providers and the patients, which was not being achieved by them. फिर हमारी पिछली हुकूमत ने भी ये कर दिया, उन्होंने भी बोर्ड ऑफ गवर्नर्स में लगा दिए और इस वक्त पंजाब के अंदर जो है कम से कम 9 इंस्टीट्यूशंस हैं जो कि बोर्ड ऑफ गवर्नर्स के तहत काम कर रहे हैं, बट अल्टीमेटली उनका आउटकम और कोई बेहतरी की ऐसी गुंजाइश नहीं आई. अगर मैं अपना थोड़ा सा जो हमारा कंसर्न एज मेडिकल एसोसिएशन है उसके लिए फिर कि हम समझते हैं एज अ सोशल वर्कर और एज अ रिप्रेजेंटेटिव ऑफ द मेडिकल प्रोफेशन एंड द कम्युनिटी कि हेल्थ इज अ राइट, इट इज नॉट अ प्रिविलेज. दूसरा जो जिस चीज को हम समझते हैं कि इसके साथ जो करते हैं कि हेल्थ डिलीवरी सिस्टम जो है, व्हाट इज द स्टेटस ऑफ हेल्थ डिलीवरी सिस्टम इन पाकिस्तान एंड द मेडिकल एजुकेशन, वो उसके लिए देखना होगा. और बड़ी राइटली कहा, वैद साहब ने भी कहा और बाकी दोस्तों को भी जो कंसर्न आ, और हमारे दोस्तों ने यू के साथ आप बैठ के भी देखते हैं कि इसके एमटीआई आउटकम जो रिफॉर्म्स जो थी केपीके के अंदर वो कैसा हुआ. मैं मतलब नॉट टू बी ऑन काइंडली फॉर गॉड से कैसा ना लीजिए कि मैं पिंचिंग ये स्टेटमेंट दे रहा हूं कि लेकिन ये सोशल मीडिया पे जब ये आए कि 20 रुपए फी घंटा आप ट्रॉली दो और वहां पे लेके आ जाओ, फिर ये जो 7-8 हमारे ऑक्सीजन के साथ ये हुए और हम ये समझे कि 2 साल के बाद देखें ये तो एडमिनिस्ट्रेटिव फेलियर्स हो सकते हैं, बट इट इज द आउटकम वहां पे देखे केपीके के साथ. और फिर अगर थर्ड पार्टी वहां पे जो हमारा हुआ है उसके लिए भी अगर हम उसको रिव्यू कर ले प्रॉपरली तो देन वी रियलाइज एंड सी कि कितने लोगों ने वहां से जॉब छोड़ा और क्यों छोड़ा, और वहां पे डिससेटिस्फैक्शन ऑफ द हेल्थ प्रोवाइडर्स और पेशेंट्स केयर के अंदर क्या क्या कॉम्प्रोमाइजेस आए, वो चीजें भी सामने आ जाएंगी. सेकेंडली, मैं एक थोड़ा सा तमाम तरह एहतराम के साथ कि जो बजट, एंड दैट इज द बजट एंड एवरीबॉडी इज वेल अवेयर ऑफ कि बजट हम खर्च क्या करते हैं उसके ऊपर, कि पंजाब के अंदर जो है 284 बिलियन जो है ये हमारे साथ, और बेड्स कितने हैं 60,387. सिंध के अंदर 139 बिलियन है और बेड्स हैं 38,600 समथिंग. केपीके के अंदर 124 बिलियन. और मैं एक कंपैरिजन की खातिर कि जिस तरह से हम सक्सेसफुल स्टोरीज को लेके आते हैं कि अगर बजट ऑफ द शौकत खान देखा जाए तो दैट इज 17 बिलियन, एंड 17 बिलियन किसके लिए है, 195 बेड्स के लिए. देखने की ये चीज है कि जो बजट हम खर्च कर रहे हैं, जो हम अथॉरिटी दे रहे हैं, हाउ इट इज ओवर देयर और कैसे और क्या होगा. सो मैं एक दो करना चाहूंगा अभी कि व्हाई ऑल इज अ चेंज इज रिक्वायर्ड, और चेंज रिक्वायर्ड करने की खातिर जो है वो हमारी एक मोटी सी चीज ही होती है, व्हाट वी नीडेड एंड व्हाई नीड इज बीन देयर, कि क्या हम एमटीआई के साथ करना चाहते हैं. तो उसके लिए सेटिस्फैक्शन हम मेरे अजीजों सिर्फ 3 लोगों की चाहते हैं. दैट इज द पेशेंट सेटिस्फैक्शन, द ट्रीटमेंट फैसिलिटीज जो सहूलतें देते हैं उनको हम चाहते हैं, या हुकूमत ये चाहती है, या मुआशरा ये चाहता है कि उसको बेहतर करे, एंड सर्टेनली द सेटिस्फैक्शन ऑफ द हेल्थ प्रोवाइडर्स एंड ऑफ कोर्स द एडमिनिस्ट्रेशन और द गवर्नमेंट. अनफॉर्चुनेटली अभी भी वेदर इट इज द एमटीआई इन केपीके और इन पंजाब और एनी अदर प्रोविंसेस ऑफ द पार्ट ऑफ दिस वर्ल्ड, पाकिस्तान के अंदर इन तीनों में से कोई एक भी मुतमईन नहीं है. मैं खुश होने की बात नहीं कर रहा, कोई भी एक मुतमईन नहीं है. अब व्हाई इट इज सो कि हमें क्या चाहिए, उसके लिए बेसिक एक ही चीज है, दैट इज दी कि हमें जॉब सिक्योरिटी चाहिए जो हम एसपीएमए समझते हैं, एडिक्वेट सैलरी सिस्टम चाहिए, सबसे बढ़ के जो मेरे नजदीक है दैट इज द जॉब सेटिस्फैक्शन. मैं समझता हूं कि फिर इसके साथ हमें रिटायरमेंट के बेनिफिट्स, एंड सर्टेनली कि अगर आप यूके में बैठ के देखते हैं यू हैव द सिक्योरिटी ओवर देयर. हमें सेल्फ रिस्पेक्ट चाहिए एज अ हेल्थ प्रोवाइडर, एज अ पेशेंट हमें सेल्फ रिस्पेक्ट चाहिए. accountability with the reward and punishment, certainly that is very much essential. और हम चाहते हैं कि rule of law हो, जो promotion है उनके साथ incentives जो हैं, that all has to be an incentive based, जिसके अंदर certainly education है, हमारी salary या incentives के साथ हमारी position है जो वहाँ पे हो, and that has to be over there and that to be taken in account. और जो मेरा मानना है इत्तेफाक से, आई वुड लाइक टू शेयर कि छोटे मोटे एक इंस्टीट्यूशन के अंदर आई हैव सर्व्ड एज चीफ एग्जीक्यूटिव एंड मेड चेंजेस ओवर देयर, और जो अभी फैसल सुल्तान मेरे दोस्त फरमा रहे थे कि केपीके के अंदर वर्कलोड भी बढ़ा और चीज़ों के साथ हुआ कि 2 बजे के बाद ज़्यादा, तब मेरे लिए बड़ी सरप्राइजिंगली ये न्यूज़ थी कि हुकूमत के हमारे हॉस्पिटल्स के अंदर कोई ऐसा होता है कि हमारे यहाँ 2 बजे के बाद हॉस्पिटल जो है वहाँ पे क्रिकेट खेली जा सकती है. देयर इज नॉट अ सिंगल पब्लिक सेक्टर इंस्टीट्यूशन कि जहाँ पे ऐसी हो, एंड आई एम श्योर कि आप दोस्त जो इंग्लैंड के अंदर हैं हैज बीन ट्रेन्ड ओवर हियर, और मेयो हॉस्पिटल आपका अपना हॉस्पिटल रहा है और वहाँ पे कैसी ये सारी चीजें आती रही हैं. मैं समझता हूँ कि फैसल साहब ने कोई मतलब एक ऐसे इंस्टीट्यूशन का दे दिया होगा केपीके के अंदर जो कि पेरिफेरी के अंदर होगा, जहाँ पे सिर्फ सर्विसेज 2 बजे तक होती होंगी और उसके बाद ना होगा. मैं समझता हूँ कि इसी तरह से कोई ऐसा सिस्टम जो हुकूमत चाहती है, that has to be with the sense of participation in the administration and serving affairs. और ये मतलब मेरे पहले दोस्तों ने भी और फैसल साहब ने भी इसको एक्सेप्ट किया कि उसके साथ होगा. इससे पहले डॉक्टर उबैद ने तो बड़ा क्लियरली इसके साथ, मैं समझता हूँ, half of my job that has been done by Dr. Ubaid, और recognition of services in the society, that is very much essential. अगर आप मुबैना गफलत, मुबैना अलाबला और इस चीज को ये समझ लेंगे कि इसके सरके के हर सरका जो करके आपने मेडिकल प्रोफेशनल्स को जिम्मेदार ठहराना है, तो बिलीव इन मी, वेदर इट इज द एमटीआई एक्ट, इट इज द पुराने सिस्टम के तहत जो बोर्ड ऑफ गवर्नर्स बने हुए हैं उनके तहत करेंगे, या गवर्नमेंट के साथ आके आप किसी तरीके को भी लाएंगे, तो नथिंग इज गोइंग टू बी आई मीन फ्रूटफुल, और कोई भी अच्छे नतीजे उसके साथ नहीं लेके आएंगे. मैं एक अर्ज कर दूं कि जैसा मैंने पहले कहा कि हेल्थ इज अ बेसिक राइट, इट इज नॉट अ प्रिविलेज. इस एमटीआई एक्ट के अंदर जो पंजाब के अंदर कम से कम अभी लॉन्च किया गया है, जो पहले बोर्ड ऑफ गवर्नर्स के साथ पिछली हुकूमत के साथ था, देयर वाज द शोर्टी अबाउट द सर्विसेज, मेडिकल एंड हेल्थ सर्विसेज जो कि अवामुन नास को फ्री ऑफ कॉस्ट देने का वहां पे था. बट इस एमटीआई एक्ट के अंदर जो एक ड्राफ्ट हमारे साथ मौजूद है उसके अंदर कतई तौर पे ऐसी चीज नहीं है. दूसरी ये कि इसके लिए जो कि फंड्स रेजिंग का जो कॉन्सेप्ट फैसल साहब ने तो कह दिया कि ऐसा कि नहीं है, तो मैं जस्ट उसके साथ दे रहा था. तो प्राइवेट प्रैक्टिस का जो एक एलिमेंट एमटीआई एक्ट के अंदर है, अगर उसकी क्लॉज 23 की क्लास नंबर 8 देखा जाए, तो जो हमारे वहां पे काम करने वाले एक्सपर्ट्स होंगे उनको पाबंद किया गया है कि वो लोग इंक्रीज इन रेवेन्यू के अंदर अपना, और उनसे पूछ कुछ भी इसके लिए हो सकेगी. तो मेरे नजदीक और हम समझते हैं एसपीएमए कि ये एक प्राइवेटाइजेशन के अंदर डेफिनेटली एक कदम है, और प्राइवेटाइजेशन के सेल्फ सफिशिएंट के नाम के ऊपर जिसको ये कहा जा रहा है कि इंस्टीट्यूशन विल बी सेल्फ सफिशिएंट, मैं समझता हूँ इसके ऊपर कतई तौर पे नहीं है. और हेल्थ प्रोफेशनल्स को और हेल्थ स्पेशलिस्टों को एक कमाऊ पूत का जो दर्जा देकर और उसके साथ ये करने की कोशिश की जाएगी, विच इज सर्टनली नॉट गोइंग टू बी गुड फॉर एनी, हमारे लिए या किसी के लिए. मैं एक थोड़ा सा एक अर्ज करता जाऊं, अगर हम समझते हैं एसपीएमए कि हमें क्या, इफ आई हैव 2-3 मिनट्स मोर, तो मैं एक शेयर कर दूं कि व्हाट इज टू बी डन, व्हाट शुड बी डन. वो मैं समझता हूं कि हमारी तरफ से ये है कि इसके लिए टू इंश्योर द फ्री हेल्थ डिलीवरी सिस्टम इन पाकिस्तान, पाकिस्तान के अंदर हर शख्स का ये हक हासिल है. And talking about the health insurance and giving the impression that it is going to be revolutionized, मैं एक चीज आपसे शेयर कर दूं कि पिछली हुकूमत के अंदर, परवेज मुशर्रफ साहब वाली हुकूमत के अंदर, लाहौर जनरल हॉस्पिटल को इसी पैराए के ऊपर ही करने की खातिर जो प्राइवेटाइज करने के लिए, और लोगों की बिड्स उसके ऊपर आ गई थी कि जो वो बिड करने की खातिर है. एंड आई एम प्राउड ऑफ इट टू बी द पार्ट ऑफ द पीएमए एस कि हमने उसको जो रोका था, और अल्हम्दुलिल्लाह वहां पे जो चीजें हैं वो बेहतर तरीके से ही हो रही हैं. मैं समझता हूं कि एस्टैब्लिशमेंट एंड इम्प्लीमेंटेशन ऑफ रेफरल सिस्टम, जिसका अभी तक हमें एडमिनिस्ट्रेशन के लिए कहा गया कि एडमिनिस्ट्रेशनली पुअर है, आई फील कि देयर शुड बी द ऑटोनॉमी फाइनेंशियल एंड एडमिनिस्ट्रेटिव विद इन द सिस्टम. अगर हम इसको ऑटोनॉमी देते हैं तो द थिंग्स कैन बी मूव वेरी नॉर्मल. और रेफरल सिस्टम के हाउ टू कम बैक कि कैसे हम इसको कम्बैट कर सकते हैं, कैसे हम मीट इन कर सकते हैं अपनी के इंस्टीट्यूशन अपनी जो है वो रेवेन्यू को बढ़ाए। तो उसके लिए मेरे नज़दीक जो था, और शुरू में मेरी ऑनरेबल लीडर ही है, मेरी बहन है बड़ी, डॉक्टर यास्मीन राशिद, एंड शी वेरी राइटली सेड एट द स्टार्ट ऑफ हर बीइंग एज द मिनिस्टर हेल्थ कि हम पंजाब के अंदर रेफरल सिस्टम जो है उसको लेके आएंगे। तो रेफरल सिस्टम को, और अगर हुकूमत और हमारे दोस्त हमसे ये समझते कि हम बात करते तो डेफिनेटली हम इसके साथ भी आते कि हाउ टू इंक्रीज और रेज द इंस्टीट्यूशनल रेवेन्यू को कैसे बढ़ाना है और कैसे उसके साथ की जाएगी। मैं समझता हूं कि ये जो फाइनेंशियल और ऑटोनॉमी है दैट इज द रेजोल्यूशन टू द इशू, और उसके साथ ये बेहतर तरीके से हो सकेगा। और लोगों के लिए मैं समझता हूं कि असेसमेंट एंड एवोल्यूशन जो है, इवेल्युएशन सिस्टम जो है, एंड दैट हैज टू बी अ 360 डिग्री। इट इज नॉट अबाउट कि जी एक आप किसी का बस्ता उठाते हैं, कोई आपको अच्छा लगता है तो आप अच्छे हो, अगर नहीं है तो दैट हैज टू बी, जो कि दुनिया के अंदर ऑब्जेक्टिवली जो है सारा ट्रांसपेरेंसी को रखने की खातिर है, बट इन एमटीआई इट इज नॉट ओवर देयर के 360। और हमने एज पीएमए कोई 10-12 हमने तजावीज पेश की थी सेक्रेटरी को। आई एम ग्रेटफुल एंड फैसल सुल्तान वेरी राइटली सेड, आई अप्रिशिएट कि सिंगल लाइनर बजट जो देने की है, मैं समझता हूँ कि इट इज वेरी गुड एंड वेरी गुड आइडिया हुकूमत को, एंड देयर इज नथिंग टू बी अ चेंज। उसके अंदर कोई चेंज करने की जरूरत नहीं है। एक सिंपल आप अमेंडमेंट और एक ऑफिस ऑर्डर के तहत अगर भेजते हैं तो चीजें वो डेफिनेटली वो ठीक हो सकती हैं। और मेरा मानना है एज मेडिकल एसोसिएशन कि जब तक आप अपने मुलाजमीन को मुलाजमत का तहफ़्फ़ुज़ नहीं देते हो तो दुनिया का कोई ऐसा काम नहीं, एंड आई विल रेफर बैक टू उबैद जो कि उन्होंने रेफरेंस दिया था किसी अमेरिकन का, कि जब तक आपके पास जॉब सिक्योरिटी नहीं है, जब तक आपके पास सेटिस्फैक्शन नहीं है टू द एम्प्लॉयज दोज हु आर गोइंग टू सर्व, उस वक्त तक कोई चीज बेहतर नहीं हो सकती। आई एम वेरी मच कॉन्फिडेंट अबाउट इट कि जो भी चेंज होगी और लोगों को दिहाड़ीदार या डेली बेजिस वाला जो सिलसिला कार करना होगा, आई पर्सनली फील कि उसके साथ किसी तौर पे भी वो ठीक नहीं होएगा। और प्राइवेट प्रैक्टिस और इसको करना कि एक प्राइवेट प्रैक्टिस के साथ हम लगा के और प्राइवेट प्रैक्टिस से हम रेवेन्यू और लोगों को, दिस ऑल इज आई मीन कोई इससे अच्छा नहीं नजर आएगा। इंसेंटिव्स अगर यही हैं कि मैंने अगर बैठ के इंस्टीट्यूशन के अंदर अपनी प्राइवेट प्रैक्टिस से अपने आप के लिए फंड्स जनरेटर करने, और फिर मैं एक्सपेक्टेशंस ये भी रखता हूँ कि वहां आने वाले किसी मरीज के साथ मैं वैसे ही डील विद करूंगा जैसा कि मैं अपने प्राइवेट पेशेंट के साथ करूंगा, तो मेरा ख्याल है कि हम बहुत बड़ी गलती के साथ हैं। ऐसा कतई तौर पे नहीं होना। मैं आपके तवज्जो से अभी आई मस्ट एक्सटेंड माय ग्रेटिट्यूड और शुक्रिया भी अदा करना चाहूंगा हुकूमत का कि हमारी कुछ रिकमेंडेशंस को इन्होंने अडॉप्ट किया इन दी एमटीआई एक्ट, लेकिन मेजॉरिटी ऑफ दोस दीज वर नॉट बिन। और एक चीज के बोर्ड ऑफ गवर्नर्स के अंदर बड़ी अजीब सी बात है कि अब मतलब केपीके के अंदर भी गालबन इन्होंने ऐसा ही किया है कि इन्होंने जो डायरेक्टर हैं, हॉस्पिटल डायरेक्टर, दैट कैन बी अ पर्सन एनीवन बट मे बी अ डॉक्टर विद द एमबीबीएस एंड सो ऑन। हम समझते हैं कि इसके अंदर बोर्ड ऑफ गवर्नर्स के अंदर डॉक्टर्स की मेजॉरिटी होनी चाहिए जो कि मेडिकल प्रोफेशनल्स हो, और हॉस्पिटल डायरेक्टर अगर लगा ही रहे हैं तो दैट हैज टू बी ओवर देयर। सो थैंक यू वेरी मच। आई थिंक ऑर्गेनाइजर देख रहे हैं, आई थिंक आई हैव गॉन आउट ऑफ टाइम। थैंक यू वेरी मच।
थैंक यू वेरी मच।
बहुत बहुत शुक्रिया प्रोफेसर अशरफ निज़ामी साहब। It was a very enlightening talk, and we obviously highlighted few kind of suggestions and caveats in the practice, and hopefully Faisal will be able to answer or give some ideas how they're going to address those.
You want me to launch the live poll now, or you want to have a debate first?
I suppose the debate first and then the vote.
So at the moment there will be 10 minutes each, Asif, for rebuttals, first by Faisal and then by Nizami Saab again, and then we'll have a poll.
Thank you.
So should I suggest, I mean, Faisal will obviously answer the queries first, which obviously...
Faisal, you have 10 minutes for rebuttal.
All right, Ji. Here it is. You start the stopwatch. I'll be within time. पहली बात, निज़ामी साहब मेरे बड़े मोहतरम हैं और बड़ी इन्होंने अच्छी बातें की। बहुत सी बातों से मैं बड़े शदीद तरीके से मुत्तफिक हूँ और इनके साथ हमारी कॉन्वर्सेशन भी रही है। पहली बात जिससे मैं इनसे मुकम्मल तौर पे मुत्तफिक हूँ, completely agree with him, is कि autonomy for the sake of autonomy will not work, and that is exactly what was wrong with the previous autonomy, and that is what's been fixed this time. उस autonomy में single line budgets नहीं थे اور اس میں جو گورننگ اینٹیٹیز تھیں اس کے اندر سرکار کا کنٹرول بہت تھا. آپ نامنیٹ سیکرٹری کو کرتے ہیں, اس کا پھر انڈر سیکرٹری اور ڈپٹی انڈر سیکرٹری جا کے اٹینڈ کرتا ہے میٹنگ. نو کنٹینیوٹی, نو اونرشپ, نو انسٹیٹیوشنل میموری. یہاں وہ کنسسٹنٹ لوگ ہیں, ڈائیورس بیک گراؤنڈ کے ساتھ, مشاورت کے ساتھ آئے ہیں. اس میں ڈاکٹرز بھی ہیں, نان ڈاکٹرز بھی ہیں. اور اگر آپ ایک ہسپتال کو چلانے کی جو اسکل سیٹ دیکھیں تو اس میں فائنانس, اس میں ایڈمنسٹریشن, انفارمیشن سسٹمز, انجینئرنگ, بہت ساری دیگر ایسی چیزیں ہیں جس کا تعلق ڈاکٹری سے ذرا باہر ہے. سو دیئر فور اس طرح کی ریئل اٹانومی از واٹ از گوئنگ ٹو ورک. دوسری بات انہوں نے کئی تھرڈ پارٹی آڈٹس کی, یہی تو بات ہم کر رہے ہیں. ان آرگنائزیشنز جو کے پی کے سامنے واحد مثال ہے نا اس وقت, the KP organizations lent themselves to this audit, asked a third party to come and give baseline تاکہ پتا چلے کہ کس چیز میں پروگرس ہو رہی ہے اور کس میں نہیں ہو رہی. بالکل اگریڈ ہوں اس بات سے. انہوں نے انڈر فنڈنگ کا ذکر کیا, آف کورس, بٹ یو کانٹ کمپیئر پر بیڈ بجٹس آف اسپیشلٹی ہاسپٹلز ود large general hospitals. اس میں کوئی شک ہی نہیں ہے that all major teaching hospitals in the country are by and large underfunded, and without sorting that یہ باقی چیزیں شاید اپنا پورا جوبن نہیں دکھا سکتی. I agree with that. انہوں نے patient satisfaction کا ذکر کیا. I have no problem at all on that concept. بالکل ٹھیک ہے. Worker satisfaction, it is very important to have an engaged, happy, committed workforce. But job security کا اگر یہ مطلب ہے کہ آپ کام اچھا کریں یا نہ کریں, there can be no action against you, so that is not the kind of job security that is about to deliver to the most important stakeholder in this, that is the patient. دیکھیے, اگر آپ خیبر کی بھی مثال لے لیں, خیبر ٹیچنگ کے بورڈ پہ for 4 years I think I served, شاید آپ ایک ہاتھ کی انگلیوں پہ گن سکیں the number of people that were thrown out, maybe not even. So the fact is کہ it has to be an accountable system, but that does not mean that no one can be asked a question or a due process followed. اچھا, یہ جو ہائرنگ اور فائرنگ کا سارا پروسیس ہے, guess who does it? ہم نے تو اس کو ڈیوالو کر کے دے دیا ہے down to the management committee, which includes all the senior medical leadership. اس میں nursing leadership ہے, finance کا head ہے, dean ہے. So the fact is that those people have been given the authority to decide کہ کیسے رکھنا ہے, promotion criteria کیا ہیں, اور instead of those people going and begging in the secretariat. ڈاکٹر صاحب نے, عارف نظامی صاحب نے بات کی, میں بالکل ان سے متفق ہوں کہ ہمیں رسپیکٹ اور ڈگنیٹی دینی ہے اپنے ڈاکٹر کو. میرے وقت میں, I'll name names then, okay, میرے وقت میں longest time خواجہ صادق حسین پرنسپل تھے کے میڈیکل کالج کے, سینئر ترین ڈاکٹر تھے, ریسپیکٹڈ ترین آدمی. آج بھی ہم ان کے جسے کہتے ہیں نا گھٹنوں کو ہاتھ لگا سکتے ہیں. لیکن جب مجھے پتا چلا ایز اے ینگ مین کہ وہ اب سیکرٹریٹ میں جا کے التجائیں یا وہ ان کو کرنی پڑتی ہیں ریکویسٹ اور یہ اور وہ ٹو میک مائنر چینجز ایون ان دی انسٹیٹیوشن, تو اٹ واز اے سلیپ ٹو مائی ڈگنیٹی ایز اے ڈاکٹر. ہم تو اس چیز کو چینج کرنا چاہ رہے ہیں کہ آپ جوتیاں سیکرٹریٹ جا کے نہ چٹکھائیں. Have your own management that then just refers to the governing board that helps you grant positions. چھٹیاں ابھی آج بھی all these senior 22 grade کے vice chancellor with in a very colonial way end up writing for چھٹیز to God knows where, and at Khyber asked the dean there کہ ان کی چھٹی کیسے اپروو ہوتی تھی اور کس ڈگنیٹی سے اور کس صورت کے ساتھ اپروو ہوتی تھی. اچھا, اس کے علاوہ پروموشن سسٹم میں نے ذکر کری تھی. ویکنٹ آفٹر آورز, سر نظامی صاحب, میں نے بالکل کسی چھوٹے اسپتال کا ذکر نہیں کیا, خیبر کا ذکر کر رہا ہوں. میں چونکہ یہاں سے جا کے میں نے کوئی 55 کے قریب میٹنگز میرے خیال سے اٹینڈ کی ان پرسن, تو آپ کو بتا سکتا ہوں کہ یہاں سے صبح صبح چلتا تھا تو 10 یا 11 بجے ہماری میٹنگ شروع ہوتی تھی. جب میں انٹر کرتا تھا خیبر کا او پی ڈی کا مین ہال, تو پل دھرنے کی جگہ نہیں ہوتی تھی. وی couldn't pass, رش ہوتا تھا. اور جب 3 گھنٹے یا 4 گھنٹے بعد میٹنگ ختم ہوتی تھی تو وہی او پی ڈی ہال خالم خالی ہوتا تھا. میرا کہنے کا مقصد یہ نہیں کہ ہسپتال خالی ہوتا ہے اس وقت. ہاسپٹلز obviously ان پیشنٹ یونٹس آر فل, کچھ تھیٹرز بھی چل رہے ہوتے ہیں, ایمرجنسیز چل رہی ہوتی ہیں. ریئل ایشو از کہ اتنی لارج گورنمنٹل پراپرٹی جو ہے وہ انڈر یوٹیلائز پڑی ہوتی ہے فار دا لارجسٹ نمبر آف آورز ان دا ڈے. آپ اور میں اگر پرائیویٹ ریسورس چلا رہے ہیں, ہم کبھی اس کو ضائع کریں اس طرح سے؟ تو میں یہ کہہ رہا ہوں اس کی بیٹر مینجمنٹ کی ضرورت ہے. تو اس میں بالکل شک نہیں کہ اچھا ریکگنیشن کا انہوں نے ذکر کیا, بالکل ٹھیک بات کر رہے ہیں, ہم نہیں ریکگنائز کرتے اچھے طریقے سے. دس ہیز ٹو چینج, اس میں تو کوئی بحث نہیں ہے. अच्छा, फ्री ऑफ कॉस्ट टू द पेशेंट एट द पॉइंट ऑफ डिलीवरी, क्या ये चेंज हुआ है? जो भी चीज खैबर में पहले हो रही थी in terms of whether the patient is paying or not, has it changed? मेरा blunt question है, and the answer is no. जिसको फ्री मिल रहा था उसको फ्री मिल रहा था. एक डिफरेंस है जो आपको बताता चलूं. खैबर में पहले भी यूजर चार्जेस टेस्ट के और स्कैन्स वगैरह के चल रहे थे, वो अभी भी हो रहे हैं. पंजाब में जब होगा तो जो अभी प्रेजेंट सिचुएशन है वही चल रही होगी. जो जिसको फ्री इलाज मिल रहा है उसको फ्री ही मिलेगा. इसमें कोई चेंज नहीं है. अच्छा, डॉक्टर साहब ने एक बड़ी मजेदार बात की. उन्होंने कहा प्राइवेट प्रैक्टिस में हम चाह रहे हैं कि वो कमाऊ पूत बन जाए. और देखें डॉक्टर साहब, कमाऊ पूत तो हमारा डॉक्टर है सो है. ही इज एक्चुअली अर्निंग एंड आफ्टर आवर वो जाके कमा रहा है. हम सिर्फ ये कह रहे हैं आपने अपनी प्राइवेट क्लिनिक या किसी और की प्राइवेट क्लिनिक या किसी प्राइवेट अस्पताल में जाके कमाऊ पूत बनना है, बिस्मिल्लाह. बट आपको ऑप्शन दे रहे हैं. इट इज योर चॉइस. यू कैन एक्चुअली कम एंड बिकम अ कमाऊ पूत फॉर योर ओन इंस्टीट्यूशन जो आपका नाम बना रही है. That is helping you build the name that you are building. तो अगर हम उस इदारे के अंदर बैठ जाएं, हम अपनी फीस जरूर लें, लेकिन साथ जो इदारे के इंस्टीट्यूशनल चार्जेस हैं वो इदारे की अपकीप मेंटेनेंस में मदद करेंगे. लेकिन सबसे बढ़ के जो इसमें चेंज है वो ये है कि जब फैकल्टी बैठी होती है शाम को इदारे के अंदर, तो उससे जो चेंज ऑफ कल्चर आता है, उनकी अवेलेबिलिटी होती है जूनियर स्टाफ के लिए और मोस्ट इंपॉर्टेंटली खुदारा मरीजों के लिए. तो ये है वो चेंज जिससे ये चीज ड्राइव होती है. उनकी प्रेजेंस. इट्स नॉट जस्ट द मनी. उसके अलावा आपने हॉस्पिटल डायरेक्टर का जिक्र किया. वो कदर छोटा मसला है लेकिन उस पर भी बात कर लेते हैं. देखिए ये हमारे कैमका के दोस्त बैठे हैं यूके में. अस्पतालों के जो मेडिकल डायरेक्टर्स हैं, जो मेडिकल लीडरशिप है, जो डीन्स हैं, वो बाहर कैफ डॉक्टर्स ही होते हैं, वो मेडिकल प्रोफेशनल्स ही होते हैं. लेकिन जो हॉस्पिटल डायरेक्टर्स हैं जिन्होंने एडमिनिस्ट्रेटिव साइड चलानी है, वो उनका डॉक्टर होना जरूरी इसलिए नहीं कि सोचें कि उन्होंने किन चीजों को ओवरसी करना है. इंफॉर्मेशन सिस्टम्स, फाइनेंस, अपना प्रोक्योरमेंट सिस्टम्स, मटेरियल्स मैनेजमेंट, क्वालिटी एश्योरेंस, ये वो तमाम और ढेर सारी और ये वो तमाम वो चीजें हैं that are not necessarily medical. In fact it is probably better to have a mix of people. कुछ जगह हॉस्पिटल डायरेक्टर्स डॉक्टर्स होंगे, कुछ जगह हॉस्पिटल डायरेक्टर्स शायद नॉन डॉक्टर्स हों, लेकिन वो स्किल सेट्स लेके आएंगे जो उसमें शामिल होंगे. अक्सर औकात फार्मेसी, नर्सिंग या एलाइड दीगर चीजों से भी वो लोग ड्रॉ हो रहे होते हैं. So very often they are medical professionals in one way or the other, and it is very important for us to come to a point जहां हम सब इकट्ठे मिलकर इसमें काम कर सकें. Again, I tremendously respect. मेरी निज़ामी साहब के साथ बड़ी बातचीत हो चुकी है, and I respect a lot of his ideas and views. और उसमें कई हमने incorporate भी किए हैं जैसे उन्होंने फरमाया. Thank you. I'll stop my rebuttal here.
That's very timely. Thank you very much, Faisal Sultan. So over to Ashraf Nizami Saab for next 10 minutes. He can obviously put his rebuttal. And after that, we'll be voting.
थैंक यू. मैं 10 मिनट से भी कम ही इंशाल्लाह कर दूंगा, चूंकि फैसल साहब ने मेरी जिंदगी आसान कर दी और उन्होंने एक्सेप्ट यही चीज जो करके कि देयर इज द मैनेजमेंट इशू रादर देन कि किसी किस्म का भी और. अभी इन्होंने बहुत अच्छे से फरमाया. प्रोफेसर हमारे सबके काबिल एहतराम प्रोफेसर सादिक हुसैन साहब और जितने भी हमारे सीनियर्स हैं, और उसने इत्तेफाक है कि मैं उम्र के उस हिस्से में आ गया हूँ कि जहाँ पे मैं भी किसी के लिए काबिल एहतराम ठहर गया हूँ. क्वेश्चन इतना सा है सिर्फ कि अगर आप सिर्फ और सिर्फ डिसेंट्रलाइजेशन के साथ करके एक सिर्फ काम करते हैं कि यू गिव अ डिसेंट्रलाइजेशन, ऑटोनॉमी टू द इंस्टीट्यूशन, एडमिनिस्ट्रेटिव एंड फाइनेंशियल, अगर ये सारा काम कर सकते हैं तो जैसा मैंने अपने शुरू में गुजारिश की थी कि चेंज फॉर द सेक ऑफ चेंज हमें करने की क्या जरूरत है. एक चीज. दूसरी चीज कि अकाउंटेबिलिटी मेरे लिए बड़ा मतलब तमाम इदारे बड़े मोहतरम हैं, लेकिन मेरी ये समझ से बाहर है कि हम क्यों समझते हैं कि हम बुरा काम करने वालों को बेयर आउट कर लेंगे और अच्छे करने वाले की हम अच्छाई को बयान नहीं करेंगे. I can never understand such an argument by anybody कि जो एक दफा पक्का होके आ गया पब्लिक सर्विस कमीशन से, सो उससे हम काम नहीं ले सकते. मैं समझता हूँ कि हमारी एडमिनिस्ट्रेशन, जब एडमिनिस्ट्रेशन चाहती है, एडमिनिस्ट्रेशन काम करती है, अपने हम एज एडमिनिस्ट्रेटर रवैये ठीक रखते हैं तो लोग काम करते हैं. और मैंने हमेशा देखा है अच्छे इंस्टीट्यूशंस को. अच्छे इंस्टीट्यूशन के साथ मेरा आर्मी का इंस्टीट्यूशन है, आर्मी के अंदर मेडिकल विंग जो है उनका वो काम करते हैं, उनकी प्रमोशंस भी होती हैं, उनकी अकाउंटेबिलिटी भी होती है गालिबन, और वो अच्छे से परफॉर्म भी करते हैं सारी चीजों के लिए। अगर इतना ही वहां पे काम हो सकता है, मेरे लिए आज भी मतलब हम सब दोस्त यहीं के पढ़े हुए हैं, गवर्नमेंट कॉलेज, माई सेल्फ इज फ्रॉम नाइट एंड आई एम वेरी मच प्राउड ऑफ इट, लेकिन गवर्नमेंट कॉलेज को आज तक कभी ये नहीं हुआ था कि वो सरकारी के अंदर रहते हुए उनके कोई ना कोई स्टैंडर्ड्स नीचे आ गए हुए। किंग एडवर्ड मेडिकल कॉलेज अल्हम्दुलिल्लाह आज भी किंग एडवर्ड मेडिकल यूनिवर्सिटी जो है वो लीड इन करती है हर चीजों के अंदर, और कहीं स्टैंडर्ड नीचे नहीं आते। मेरा सिर्फ इतना मानना है और पाकिस्तान मेडिकल एसोसिएशन का ये मानना है कि खुदारा चीजों को ऑड प्लॉट करने की बजाय वो चीजें जो पॉजिटिव हमें चाहिए और सिर्फ एडमिनिस्ट्रेटिवली एक सिर्फ स्टिक के साथ आप सीधी चीजें कर सकते हैं तो उनके साथ रखें, बजाय इसके कि वो सिस्टम जो कि इंपोर्टेड हम समझते हैं कि अमेरिका बेस्ड या ब्रिटिश बेस्ड। एक आपसे मैं प्रोफेसर वहीद साहब गालिबन हम में से बहुत से उस्ताद भी होंगे, उनका एक बड़ा अच्छा कहना था विच आई एवर फॉलो, मतलब जस्ट मेरे जहन के अंदर एक बात आ गई कि वो मतलब ब्रेस्ट फीडिंग के लिए बड़ा कहा करते थे। तो ब्रेस्ट फीडिंग के लिए उनका एक बड़ा मतलब एक शोला आफाक किस्म की चीज थी कि उन्होंने फरमाया कि बछड़े का या गाय का जो होता है दूध बहुत अच्छा है, लेकिन गाय का दूध जो है वो गाय के बच्चे के लिए दूध अच्छा होता है। सो अमेरिका के निजाम बड़े अच्छे होंगे, ब्रिटेन के निजाम बहुत अच्छे होंगे, लेकिन खुदारा मत समझें कि पाकिस्तान के अंदर जो चीज है ये सब कुछ ही गलत है और उसको A to Z हम चेंज करके उसके लिए। तो मैं एक तो इस अकाउंटेबिलिटी से कतई तौर पे मैं मुत्तफिक नहीं होगा कि लोगों को कि आपकी जॉब की, देखें आप लोग कैंपा के मैं दोस्तों से जो ब्रिटेन में करते हैं, आपका ये प्रॉब्लम नहीं है कि आप कल को क्या करेंगे। खुदारा पाकिस्तान के अंदर जब तक आप अपने काम करने वालों को सेंस ऑफ सिक्योरिटी नहीं देंगे, उनको सेंस ऑफ लीडरशिप और सेंस ऑफ इन्वॉल्वमेंट इंस्टीट्यूशन के अंदर नहीं देते, चीजें अच्छे से नहीं हो सकती। आई एग्री एज अ गवर्नमेंट, एज फैसल सुल्तान साहब कहा कि लोग काम करने या ना करने वाले चूंकि जजा और सजा का कोई सिस्टम नहीं है उस वजह से होगा, लेकिन एट द सेम टाइम मैं समझता हूं कि पाकिस्तान के अंदर हमारे ऐसे इंस्टीट्यूशंस मौजूद हैं, एग्जिस्ट करते हैं। मुझे अपना कहते हुए अच्छा ना लगेगा, लेकिन मैं फैसल साहब के लिए कि मतलब आई वाज एट द शौकत खानम और जबकि चीफ एग्जीक्यूटिव साहब वो दौरा कर रहे थे बाहर आके, एंड आई अप्रिशिएटेड हिम कि यार ये तो आप बहुत अच्छा फैसल साहब कर रहे हो, एंड द सेम डिड आई व्हेन आई वाज ऑन एन इंस्टीट्यूशन, मजदूरों का एक इदारा जिसके साथ करके, और मुझे कतई तौर पे खुदा शाहिद है कि हमने तो एंट्री के लिए मतलब ये एक परफॉर्मेंस, ये कहते हैं जी एमटीआई जो अटेंडेंस बड़ी बेहतर कर देगी। मेयो हॉस्पिटल के अंदर आई सर्व्ड इन ऑर्थोपेडिक सर्जरी प्रोफेसर नसीर साहब के साथ नीचे रहते हुए व्हेन आई वाज रजिस्ट्रार ओवर देयर, तो हमारे यहाँ तो रजिस्ट्री का मतलब रजिस्टर ही नहीं था, बट देयर वाज नो कॉन्सेप्ट कि ऐसा भी होगा कि कोई बंदा नहीं आएगा या अपनी ड्यूटी नहीं करेगा। मैं समझता हूं कि गिव द सेंस एंड फील ऑफ रिस्पॉन्सिबिलिटी, लोग काम करेंगे इंशाल्लाह। अब फ्री सर्विस और यूजर चार्जेस के लिए मैं तो सच्ची बात है आप दोस्तों से शेयर करूं कि अगर पंजाब के अंदर अंडर दी अम्ब्रेला ऑफ यूजर चार्जेस मिलते हैं तो ये भी चीजें गलत हैं, ऐसा नहीं होना चाहिए। लोग बेचारों के पास जाके उनसे कभी पूछें कि कैसे वो कपड़े बेच के और अपनी जमीनें बेच के इलाज मुआवजे के लिए आते हैं। और अगेन आई विल मतलब केपीके के अंदर के पठान दोस्त हमारे जो है इलाज मुआवजे के लिए क्या कुछ करते हैं और बड़ी अच्छी वहां पे चलती है। सैलरी स्ट्रक्चर इट इज वेरी मच सिग्निफिकेंटली इंपॉर्टेंट, और उसके लिए कि आप प्राइवेट सेक्टर के अंदर इनिशिएटिव दे रहे हैं कि प्राइवेट सेक्टर के लिए जाके प्रैक्टिस करें। मैं समझता हूं एसपीएमए के पीपल शुड हैव टू ऑप्ट वन वे, आइदर द पब्लिक सेक्टर और द प्राइवेट सेक्टर। प्राइवेट इंस्टीट्यूशंस जो है इनको ग्रो करना है पाकिस्तान के अंदर, और आज बेहतर समझते हैं कि इस वक्त मेडिकल कॉलेजेस की तादाद भी प्राइवेट के अंदर ज्यादा है, प्राइवेट इंस्टीट्यूशंस की तादाद भी ज्यादा है, और अगर हम बेड स्ट्रेंथ भी देखें तो प्राइवेट इंस्टीट्यूशन और 70% ऑफ द, ये मतलब मैं बड़ी जिम्मेदारी से कह रहा हूँ कि 70% पेशेंट केयर इज दैट इज डन बाय द प्राइवेट इंस्टीट्यूशन एंड प्राइवेट केयर। तो इस वजह से ये समझना कि हम उसको बेहतर करेंगे या नहीं। और मैं एज अ ट्रेड यूनियनिस्ट मतलब आप कह लीजिएगा कि रिप्रेजेंटेशन ऑफ द पाकिस्तान मेडिकल एसोसिएशन एंड कम्युनिटी, आई हैव टू सेफगार्ड। मैं नहीं चाहूंगा कि सुबह के वक्त आप आते हैं तो आपको एक कागज पकड़ा दिया जाए कि योर सर्विसेज आर नो मोर रिक्वायर्ड। आई थिंक ऐसा दुनिया के अंदर नहीं है, और यहाँ पे जो किया जा रहा है, जो सिस्टम के साथ चीजें की जा रही हैं, ये इट इज गोइंग टू बी, आई एम सॉरी मेरे जहन के अंदर कोई और मुहज्जब किस्म का लफ्ज नहीं आ रहा, ये हम शोबा सेहत के साथ एक खिलवाड़ी करने चले जाएंगे। हॉस्पिटल डायरेक्टर्स की जो मैंने बात की कि उसके लिए यस वी हैव दी, मतलब लोग पोस्ट ग्रेजुएशन करते हैं और एडमिनिस्ट्रेशन के अंदर ही करते हैं। फैसल सुल्तान बुरा नाम नहीं, चूंकि अभी पीएमसी का भी जो हाल हमारे साथ सामने आया है तो जिम्नन में उसका तस्करा करने के लिए, बट इट इज वेरी पर्टिनेंट टू मेंशन ओवर हियर कि वो लोग जिनका काम नहीं है जब काम करेंगे तो इश्यूज खड़े होंगे। ابھی آپ نے پورے پاکستان کے اندر اس کا کر دیا اور پاکستان کے ساتھ ایڈمیشن پروسیس کے اندر
میری ریکویسٹ ہوگی جی, سوری آئی ایم بٹنگ ان, بٹ I therefore should be allowed to respond to this as well.
Okay, sure. مجھے تھوڑا سا, میں فیصل صاحب اجازت.
ایک منٹ, can I just
But that's up to the organizers. If you talk about the PMC, پھر میں اس کو بھی ریبٹ کرنا چاہوں گا.
فیصل ایک منٹ آپ ذرا مجھے موقع دیجیے. اشرف بھائی, can we ایک منٹ, just let me just point out that the debate topic is the MTI reforms improve service. So if we can stay focused on improvement of service element, then I will obviously ask Faisal to answer at the end. Yeah, thank you.
Thank you. It was my, in addition to all that, کہ MTI services اور جو میرا argument ہے, اور اس کے لیے اگر آسانی سے کروں کہ جس کا کام اسی کو ساجے کی بنیاد کے اوپر ہی تھا, کہ جب ہم کام کو سب چیزوں کو انفولڈ کر کے ایک سینٹرلائز قسم کی چیزوں کی طرف لے کے جانے چاہیں تو چیزیں جو ہے وہ ہمارے ساتھ درست نہیں ہوتی ہیں. I'm sorry, میں نے پہلے فیصل سے معذرت کر رہی تھی کہ مطلب اس کو he may mind it کہ میں نے ایسے کر دیا, لیکن it was nothing special. Faisal is very dear to me, or I have a lot of respect and regard for him. Thank you.
Thank you very much, Ashraf Nizami-Debate. And that gives me some time to ask Faisal. He wanted to reply to.
نہیں, I was just referring کہ اگر نظامی صاحب PMC کی بات کرتے ہیں تو پھر اس کو مجھے کلیریفائی کرنا ضروری ہوگا, لیکن چونکہ انہوں نے خود ہی کہہ دیا تو we'll stop it there. Let's not go. ہم اسی ٹاپک پہ رہیں جس کو ذکر کر رہے ہیں.
Sure.
Thank you.
Anything, Faisal, you want to raise to Ashraf Nizami Saab?
نہیں, no, دیکھیں میرا خیال ہے کہ perhaps there is less to disagree and more to agree. جو اینڈ مے بی کچھ ممکن ہے کہ کچھ چیزیں جو ہیں وہ کلیئر بھی نہیں ہیں. وہ میں یوزر چارج ایک تھوڑا کلیئر کر دوں. سر یوزر چارج چونکہ پنجاب میں ہے نہیں تو یہاں وہ انیکٹ بھی نہیں ہوگا. میں صرف یہ کہہ رہا تھا کہ چونکہ آئی وانٹڈ ٹو بی کلیئر تاکہ میرے منہ سے کوئی غلط بات نہ نکلے, چونکہ KPK میں پہلے سے یوزر چارج چل رہا تھا تو وہ چلتا رہا. پنجاب میں چونکہ نہیں چل رہا تو یہی ایکسپیکٹیشن ہے کہ یہاں نہیں ہوگا. سو خدا نخواستہ ایسا کوئی مسئلہ نہیں ہے جو کہ that's just one minor clarification. باقی دیکھیں this is a debate that can go on till the cows come home. سر نے بڑی اچھی اور اہم باتیں کی ہیں, میں نے ان کو ریبٹ بھی کرنے کی کوشش کی ہے, انہوں نے ان کے کاؤنٹر آرگومنٹس بھی دیے ہیں, but this is how civil debate is. That's fine, we stop it here.
اچھا صاحب, یس آپ کوئی بات
نہیں, میں صرف فیصل سے ایک ہی شیئر کرنا چاہوں گا کہ یوزر چارجز پنجاب کے اندر ہیں. There are certain institutions and on their own. اگر میں تھوڑا سا مطلب ریڈیولوجی کی بات کروں تو لاہور جنرل ہاسپٹل از بیہیونگ انٹائرلی ڈفرینٹ. میو ہاسپٹل کی بات کریں تو وہاں پہ ڈفرینٹ ہے. تو دیر آر انڈر دا یوزر چارجز, لیکن یہ ایسا کوئی فکسڈ بائی دا گورنمنٹ کوئی قانون ایسا نہیں بنا ہوا کہ کچھ لوگ کریں گے کچھ لوگ نہیں کریں گے. اینڈ دیر آر سرٹنلی دی بورڈ آف گورنرز اور ان کے تحت یہ ساری چیزیں چلتی ہیں. دیٹ از اے اسٹیٹ آف کنفرن, بٹ دیز آر دا مائنر سرٹن.
My question to both, obviously Faisal first and then to Ashraf Saab, how we can bring the end user, who is the patient, their point of view into delivery of service. Faisal first, be brief, and then Ashraf Saab.
Very simple. اس کے دو راستے ہیں جی. ایک انسٹیٹیوشنلائز رستہ ہے, ایک انفارمل ہے. جو انسٹیٹیوشنلائز رستہ ہے وہ تو یہ ہے کہ جو گورننگ بورڈ کے ممبرز ہیں, اسی وجہ سے ہم کمیونٹی اس جگہ میں سے یا لوگوں کے ریپرزینٹیو ڈائریکٹلی انڈائریکٹلی سول سوسائٹی کے کچھ ایکسپرٹیز رکھتے ہیں, وہ ایکسیسیبل لوگ ہیں, دے آر ناٹ ڈسٹنٹ سول سرونٹس. تو ایک تو ان کے پاس یہ چیز آتی رہتی ہے. ہم خیبر کی میں آپ کو مثال دے دیتا ہوں, ہم 5-6 جو بورڈ ممبرز تھے, ہمیں لگاتار شکایتیں, خیالات, تجاویز آتی رہتی تھیں. تو ایک یہ وہ چیز ہے. لیکن میں سمجھتا ہوں کہ وہ بھی طریقہ پراپر اور ٹھیک نہیں ہے. جو اصل بہترین طریقہ ہے وہ ہاسپٹل کے اندر جب تک آپ پیشنٹ کوالٹی اینڈ سیفٹی کا محکمہ جو کہ رسپانسو ہو مریض کی شکایات اور ان کے معاملات حل کرنے کا, وہ نہیں بنائیں گے, اور وہ امپاورڈ ہونا چاہیے. اس کی دسترس آل دا وے ٹو دا بورڈ اینڈ چیف ایگزیکٹو فرسٹ آف آل اینڈ دا ہاسپٹل ڈائریکٹر, میڈیکل ڈائریکٹر. تو یہ جب ہوگا تو خود بخود چیزیں جو ہیں وہ ٹھیک ہونی شروع ہو جائیں گی. لیکن بہرحال یہ پروسیس ہے, یہ ایک دن میں نہیں ہوگا.
اچھا نظامی صاحب, آپ کیا سجیسٹ کرتے ہیں اس کے بارے میں؟
जी सर, मैं समझता हूँ कि वी आर ऑन एग्रीमेंट विद डॉक्टर फैसल, किसी उसके ऊपर हमारा कोई इख्तलाफी नोट नहीं है. Certainly we are for the improvement in health delivery system and me too as Pakistan Medical Association. लेकिन हम समझते हैं कि इसके साथ autonomy with the financial और plus जो administrative हो, तो चीजें बड़ी अच्छे से सुलझाई जा सकती हैं, चीज पे हो सकती हैं. We have to make people responsible. और certainly आपने बिल्कुल दुरुस्त कहा कि ultimate हमारी satisfaction, that is the patient care is very much important. जिस apathic और इस किस्म के हमारे रवैये हैं, we as health professionals and the health institutions, we have to readdress in a proper way. और उसका सिर्फ और सिर्फ एक ही हल है जो कि ये MTI के तहत चाहते हैं. और रिपीटेडली मतलब मेरे दोस्त फैसल इसी बात को कह रहे हैं कि वहीं पे फैसले होंगे. तो जब मैं भी समझता हूँ कि जब हम फैसले वहीं इंस्टीट्यूशंस के अंदर ही करेंगे तो चीजें इंशाल्लाह दुरुस्त और अच्छी होंगी. और इसमें सबसे इंपॉर्टेंट है दैट इज द पेशेंट, कि पेशेंट की वहां पे पार्टिसिपेशन बहुत जरूरी है. मैं एक मेडिकल कॉलेज में था और अमेरिका में मैंने सुना है कि वहां कुछ है, और जब वहां पे एकेडमिक काउंसिल हुई तो मैंने ये प्रपोज किया कि देयर शुड बी द मेंबर बाय द स्टूडेंट्स इन अ पार्ट ऑफ एकेडमिक काउंसिल, कि हाउ दे वांट टू लर्न. हम समझते हैं, मतलब मेरा पहला ही इख्तलाफ ये हो गया कि जो मेरे भी सीनियर टीचर थे उन्होंने कहा नहीं नहीं नहीं, पहले तो ऐसे ही होता था, ऐसे ही होगा. मतलब हाउ दैट कम बी ओवर देयर. तो मैं समझता हूँ कि जब भी आप डिसीजन लेते हैं पार्ट ऑफ द सोसाइटी, जब उनके साथ आता है पेशेंट शुड बी देयर, और उनके साथ जब हम पूछेंगे, जब उनसे देखेंगे तो चीजें इंशाल्लाह वो बेहतर होंगी. और अगर हुकूमत अगर एसोसिएशंस को कहते हैं, मतलब एक लफ्ज यूज किया जाता है स्टेक होल्डर्स, और हमने उनके साथ देखा, हमने हेल्थ प्रोफेशनल्स को पूछा. अब एक बेचारा प्रोफेसर जो मतलब सरकार का मुलाजिम है, हाउ कम्स सिटिंग विद द सेक्रेटरी हेल्थ या फैसल साहब के सामने बैठ के वो बात कर देगा? मेरा ख्याल है कि ऐसा नहीं है. देयर शुड बी द एसोसिएशन, दोज हु आर द रिप्रेजेंटेटिव, they will be real assisting the government, and we as PMA, we are assisting the government, not matlab we are critical certainly on certain situations or certain matters. That's it. Thank you. Thank you very much.
Thank you. इसमें I mean मैं इस मौके पे एक और क्वेश्चन रेज करना चाहूँगा कि जिस तरह यूके में हम लोग करते हैं एक फैमिली एंड फ्रेंड टेस्ट, कि जिसमें जो पेशेंट और उनकी फैमिली को हम क्वेश्चनर्स देते हैं कि वो हमारी सर्विस को कैसे रेट करते हैं, उसकी बेस पे और वो अपनी सजेशन भी उसमें दे सकते हैं. लेकिन उसमें यह है कि उसकी बेस पे हम कंपेयर करते हैं कि हमारा हॉस्पिटल जो है हाउ इट इज़ परफॉर्मिंग, कि उनकी नज़र में, क्योंकि इन दी एंड हम सर्विस तो उन्हीं के लिए प्रोवाइड कर रहे हैं. तो उसके लिए फैसल और अशरफ निज़ामी साहब आप बताइए कि हाँ आप इस चीज़ को कैसे इम्प्लीमेंट कर पाएंगे या ये रेलेवेंट नहीं है?
बहुत रेलेवेंट है राना साहब. इफ आई कुड से आखिरी टेस्ट ही यही है. वो ये है कि क्या हमारी सर्विस पे जो हमारा मरीज आ रहा है, क्या वो खुश है हमसे या नहीं. और इसका जैसे मैंने कहा कि जो पेशेंट क्वालिटी सेफ्टी डिपार्टमेंट्स हैं, दे नीड टू बी एस्टैब्लिश्ड एंड स्ट्रेंथन्ड. और उनके पास ताकत होनी चाहिए कि वो ये पुश और पुल दोनों तरीके से ये इंफॉर्मेशन ले सकें, सर्वेज के जरिए भी, और फिर अगर किसी को उस वक्त मौके के ऊपर जो एतराज या मसला हो उस तरह से भी. पुश एंड पुल बोथ वेज. यू डू एन एक्टिव सर्वे एंड यू आल्सो अलाउ पीपल टू टेल, और वो डेटा कोलेट होके हॉस्पिटल लीडरशिप के सामने रखा जाए ताकि वो उसको उस पर अमल कर सकें. और मैं आपको शौकत खानम की मिसाल दे देता हूँ. आई थिंक आसिम इज चेयरिंग द सेशन, ही विल बेयर मी आउट, कि हर क्वार्टर हर बोर्ड मीटिंग में जो हमारा पूरा डैशबोर्ड है शिकायत का, सेटिस्फेक्शन का, तजावीज का, and benchmarking it against international and our local numbers, वो बोर्ड को पेश किया जाता है. और जो हमारे अपने गलतियां होती हैं और सब इदारों से होती हैं वो सामने रखी जाती हैं. तो ये कल्चर हमें लाना पड़ेगा, और इंशाल्लाह मैं समझता हूं कि हम एक रास्ते से लाएं या दूसरे से. अब ये जरूरत वक्त है आज. दिस इज द टाइम, दिस इज द नीड ऑफ द आवर.
थैंक यू. अच्छा साहब, आप कुछ कहना चाहेंगे या मेरा एक और क्वेश्चन है?
हाँ जी, मैं समझता हूँ कि बिल्कुल दुरुस्त है, और आपने वेरी राइटली सेड कि पेशेंट इज द अल्टीमेट, सेटिस्फेक्शन ऑफ द पेशेंट इज वेरी मच इंपॉर्टेंट. लेकिन हमारे यहाँ रहते हुए पाकिस्तान के अंदर जो मैं समझता हूँ कि इसकी इन्वॉल्वमेंट और उसकी असेसमेंट और सारी वैल्यूज को लेने के लिए दैट इज द रेफरल सिस्टम, के जब तक हमारे मुल्क के अंदर रेफरल सिस्टम जो है वो इस्टेब्लिश नहीं होता, आप सब चीजें फ्री फॉर ऑल करके ऐसी चीजें नहीं दे सकते जब तक आपके पास नंबर ना पता हो. और अगर मुझे थोड़ी सी इजाजत दे दें, व्हाट आई मीन बाय द रेफरल सिस्टम, उसके आने की खातिर जो है कि हमारे यहाँ सपोज जना हॉस्पिटल है, एंड दैट शुड बी अ टेरिटोरियल. हमारे यहाँ माशाल्लाह आप सबके पास CNIC नंबर है, मौजूद है, and make it कि ये जी 10 लाख को आबादी को कैटर करेगा, 5 लाख को कैटर करेगा, 2 लाख का कैटर करेगा, जो हमारे पास से रिसोर्सेज है उन्हीं तरह के इनकी डिवीजन कर दी जाए, एंड सिस्टम इज ओवर देयर, और असेसमेंट और इवैल्यूएशन का सिस्टम दैट कैन बी इम्प्रूव्ड, और सर्टेनली दैट इज द ओनली वे। ऐसा नहीं हो सकता कि आपके यहाँ एक इमरजेंसी में पेशेंट आता है, ही कैन वेट ओवर देयर, आप मतलब ट्राइएज करते हैं, सारी चीजें देखते हैं एंड रिमेन अवेटिंग। मेरे मुल्क के अंदर ये है कि जो मरीज आया है इमरजेंसी के अंदर कहता है कि सबसे पहले मुझे देखा जाएगा और मेरी ही सर्जरी और सारी चीजें होनी चाहिए, एंड इट इज हैपनिंग इन पाकिस्तान अल्हम्दुलिल्लाह। आई फील कि पाकिस्तान के अंदर हमारी जो इमरजेंसी सर्विसेज हैं गालिबन टाइम लाइन के हवाले से देखा जाए तो उनका गालिबन अगर हम असेसमेंट करें, गालिबन क्या मतलब डेफिनेटली, तो हमारे यहाँ बेहतर तरीके से वो चीजें हो जाती हैं। सो आई एग्री विद यू कि सेटिस्फैक्शन ऑफ पेशेंट बट इवॉल्विंग द सिस्टम, रेफरल सिस्टम इज वेरी मच एसेंशियल, और ये कोई बड़ी रॉकेट साइंस नहीं है, ये मेरा अफर्म बिलीव है, इसके खातिर कोई भी यहाँ पे हुआ जा सकता है।
बहुत बहुत शुक्रिया जी। एक और आखिरी जो है मैं सवाल करूंगा दोनों से, उसके बाद जो है आई विल आस्क आसिफ टू रन द वोटिंग। द क्वेश्चन इज के वी टॉक अबाउट एथिक्स, के how actually we can implement ethical practice, and will there be, MTI will be introducing some kind of educationalist on medical ethics, and is it really important or just जैसा चल रहा है चलने दें? तो one liner from Faisal and from Ashraf Nizami, and then open for voting.
भाई जी, आई थिंक इम्पोर्टेंट तो बहुत है, और इसको कैसे किया जाए वो उसके मुख्तलिफ तरीक़ाकार हैं, बट मोस्ट इम्पॉर्टेंट इन दैट इज टू पहले एक्चुअली आपका एथिकल फ्रेमवर्क इदारे के अंदर आपने इस्टेब्लिश करना कि क्या चीज़ ठीक करनी है, क्या ठीक है, क्या नहीं ठीक। कई दफ़ा गलत चीज़ें जो हैं वो सही का लिबादा ओढ़ लेती हैं, हमें भूल ही जाता है कि गलत है। बहुत सी छोटी छोटी चीज़ें, मैं मिसालों में नहीं जाता, लेकिन एथिकल फ्रेमवर्क आप इस्टेब्लिश करें और उसके मुताबिक लोगों को तालीम भी दें, सेंसिटाइज भी करें, और फिर उनको चेक भी करें, और एक बतदरीज प्रोसेस के थ्रू एथिकल फ्रेमवर्क डेफिनेटली इम्पोज और इन्फोर्स होना शुरू हो जाता है। और मेरा ख्याल है कि ये अगर आप किसी भी इंटरनेशनल सर्वेयर को देखें तो वन ऑफ द मोस्ट क्रूशियल थिंग्स दैट दे एंड अप सीइंग इज वेदर देयर इज अ कल्चर ऑफ एथिक्स और एन एथिकल प्रैक्टिसेस इन द ऑर्गेनाइजेशन और नॉट।
Ashraf Nizami sahab, a few words, and then I will ask Aasim Yusuf as a chair to come in. Ashraf Nizami sahab.
जी सर, मैं समझता हूँ कि एथिक्स दिस इज वेरी मच एसेंशियल, और सर्टेनली कि इसको मतलब रिलेटिवली चीजें देखी जाती हैं, एंड वी इन पाकिस्तान एंड बीइंग आवर रिलीजन एंड सो ऑन, मोरालिटी इज द मेन बेसिक। एथिक्स की खातिर आप डेफिनेशंस के साथ, बेसिक राइट्स के साथ आप डिफरेंशिएट कर सकते हो, लेकिन एथिक्स सर्टेनली मेडिकल एथिक्स मैं समझता हूँ कि इसका मेरा बड़ा मानना है, एंड दैट हैज टू बी इम्प्लीमेंटेड बाय ऑल मीन्स।
Thank you. Aasim Yusuf sahab, as the chair, can you kindly just take few words before we run the voting?
Right. Well, thank you, everyone. I'd like to thank all the speakers, first of all. Professor Obaidullah from KPK, Ashraf Nizami sahab, Dr. Faisal Sultan. Very interesting debate, very lively thrust and counter thrust, rebuttals and so on. Let's see how the voting goes. From a personal point of view, I've enjoyed the entire 2-hour session very much. I look forward to the rest of the meeting, and I'd like to congratulate you all for pulling it off in this very difficult time. The only glitch being my own power cut, so I'm sorry about that.
Thank you.
Let's start the voting and see how things go.
Thank you very much. Before I start voting, I want to pass on message from our Health Minister, Dr. Yasmin Rashid. I apologize because due to health condition that she will not be able to attend the sessions today, so just apologize. So I will launch the voting. Everybody can vote, including the panel, and it will be a anonymous one, and we will publish the results within 1 minute. So you will have 60 seconds to vote, and then we can have so voting is live now. We have like 210 participants and 10 panelists, so we'll definitely expecting so 30 more seconds before we end the. We have already got more than 30% votes. हमारे वोटर्स एंड पे जल्दी आते हैं. I think the attendees can also vote if they are still there. We have last 10 seconds before we finish this. Okay, so the turnaround of polling is only 40%. And I'm going to share the results. Okay.
Right, we've got 40. Asif, you can actually declare. I have lost the screen.
Okay.
Or Athar bhai, you want to do it? Dr. Athar Saeed? Can you see the screen, please?
I can see the screen if you want me to declare the results.
Okay, Asif,
Go ahead.
you go.
So
We have to do.
the people who have voted for improving the MTI reforms will improve service is 54%. The people who said MTI reform will not improve service is only 15%, 1-5. And there are 31% people are unsure. So I think the voting that yes, MTI reforms will improve service, 54%, but there are 30% people who are unsure as well.
We need to work on them. Dr. Faisal, Dr. Yasmin need to spread the message further.
If I could just on a light note just say that I think people are watching it. They are saying, "Dekho,
Yeah.
dekho, hum kaise karte hain aap."
Oh, but there's 30% of people with an open mind, which is very good.
Yes.
You do need open-minded people as well who can actually influence the results in later stage. So I think
And
that
we
will
certainly shouldn't
be
take anyone's support for granted.
Yeah.
That's right.
Perform.
So
Dr. Athar
housekeeping,
Saeed,
I
want
will
to say something? Dr. Athar Saeed, for concluding remarks, please.
Oh, thanks. It has been a great debate. I thoroughly enjoyed it. There was a lot of interest. It was lively and I think very productive. And I think both sides will take away more informed messages, and perhaps that will help towards formulating, modulating policies. So thoroughly enjoyed it. Excellent. I can just say one or two things. We have a poster session now over on channel 2, if you're interested. And we will join the other session, which is the plenary session at 6 o'clock your time. We have a presentation by a famous economist, Maruf Ali Sayyid, to start with. After that, Chima will talk about training in Pakistan and abroad. Yasmin Rashid, unfortunately, is poorly. She won't be able to join. And Faisal has another talk starting 7:20 your time, Faisal, so that you can tell us about the role of the Federation after devolution of health services to the governments. And after that, there is a ceremony. We have a few achievement awards to give. And as I said earlier, there is a surprise event especially for the KE alumni, which Khalid Gondal has in store, which only he and myself are privy to. So that will be a surprise for all of you, especially those who are abroad. So thank you very much. And if you would like to join channel 2, you're welcome. Otherwise, I'll see you at 6 o'clock your time.
So this channel will stay live. We'll go on a break, but you can join the same link, people who have a channel 1 link, again in 1 hour time.
And if all of you can turn your cameras on, if I could take a picture. Obaidullah Sahab, if you're still there, and Saeed Ahmed Sahab, if you have the camera.
Thank you.
Thank you.
Thank you very much, everyone. Thank you.
Thanks.